my pleasure to welcome you to, I don't know what number it is, but we have been doing the Coli Institute Imaging Summit now here for almost a decade. It's my pleasure to welcome everybody. A couple of our colleagues who normally would make it were unable to travel over. Justice Ehlers says that he missed his flight, but I just don't think he likes fish. So we're going to still roll with all the talks, and we're going to have, I think, an incredible time. Just like a couple of housekeeping slides just for everyone's. Oh, excellent. So this is activity jointly provided by the Clinical and Patient Educators Association, IVISTA. We have commercial support through multiple grants, specifically Apellis, Genentech, Topcon, Regeneron, and Zeiss. Like to, during our breaks, please visit our sponsors. I'd like to thank our exhibitors and sponsors. We can't do this without their assistance and have you here and support this meeting. You can claim credit. If you'd like to claim credit, check in at the meeting registration desk. After the meeting adjourns, just scan the QR code and you have to do a do a post-test, an evaluation, and you'll be able to get your certificate. Please rate Sumit Sharma highly. He wants to come back next year. With that, I'm going to give the agenda to Sumit. Sumit's going to take over for a bit, and I want you to introduce our first speaker.
Great. Thank you, and welcome everyone. So our first speaker is Dr. Anant Lowenstein, who's very, very well known. Doesn't really need an introduction, but I'm going to give her one anyway. So she's a full professor of ophthalmology. She's vice dean at the Faculty of Medicine at the Tel Aviv University and head of the Department of Ophthalmology. And she's actually going to be giving us two talks because she's going to be running over to the president's dinner right after. So her first talk is on the role of AI in home monitoring, and then it'll be hypertransmission defects as an endpoint in GA trials.
There is a timer, so I don't need my phone.
We'll yell at you if you're late, don't worry.
I'm really excited and humbled to be invited to give a talk at this meeting, and unfortunately I have an ASRS function that I need to attend, so I will need to leave after my talks. Hopefully there'll be some time for questions. So my first talk is a topic that I'm dealing with for many years, and this is home monitoring, and specifically I'll emphasize the role of AI in our technology. This presentation describes an investigational use of a medical device, but the FDA recently did grant marketing authorization for the first home OCT. Basically, this established, this de novo market authorization led to the FDA establishing a new class of devices. So when we see these two patients, they look very similar. On visit 1, they have subretinal fluid. On visit 2, they have subretinal fluid. However, they're very different in what happens to them in between the visits. In patient 1, there is no fluid between the visits, and the fluid only appeared at visit 2. Maybe in this patient, you would consider shortening the time interval when you see him for re-injection. In the second patient, there was fluid all along. So maybe in this patient, you would consider switching to a different drug. Sorry, Dan, I know that switching is not allowed.
I like the plug immediately. That's good.
Anyway, so the home OCT actually carries the potential to provide a lot of information of what happens in between visits. And as you can see in patient 1, all along in the trajectory, there was nearly no fluid until really just before the visit, whereas the second patient had fluid all along. And this is even more important today when we have all these new treatments that carry the potential of longer time interval between treatments. 60% can go 4 months, 80% can go 3 months. And in between this time, we need to think how we monitor these patients. We are in a new era of treatment. Probably we also need some new ways to monitor the patients in between. And here comes the role of AI, because if you want to do nearly daily remote monitoring, the physician cannot, it's not feasible for him to really deal with all this data without AI. They cannot cope with the daily OCTs that the patients are doing. So basically, what the AI power algorithm it does is automatically quantify the relevant biomarkers. So here you can see the volume scan with the hyperreflective spaces overlay. You can see the hyperreflective spaces projection, and you can see how the AI converts these three-dimensional volume scans to a one-dimensional biomarker trajectory, which makes it very easy for the physician. So the way the flow goes is that the ophthalmologist refers the patients to the monitoring center. The monitoring center, he provides the patient with the technology and then makes sure that the patient is regularly monitoring himself. The patient's task is to do daily OCT scans. The images are mounted on a cloud, analyzed by the AI, and then the ophthalmologist can actually review the images, the projection maps, the trajectories. He can set the threshold for notification by the monitoring center. And there are opportunities to bill for the physician, for the monitoring center, and for the patient copay. So if the notification happens, it can be a notification that was determined according to a preset volume threshold that was achieved, or if the physician said that he wants to see the patients in any event after a certain time period. And then if he's invited to the clinic, and if the commercial OCT shows that there is fluid, he is treated and continues the monitoring. So this is the pivotal trial that led to the approval. There were 180 patients, and the study showed basically that there was a high agreement between the home OCT and the commercial OCT. Patients in 97% were able to activate the technology. They were very adherent with 6 scans per week and with very good repeatability. So this is the indication for use. It's the first ever approved AI for OCT imaging and home-based imaging technology and 3D imaging medical device. We have many other studies over the years, studies showing practicalities, showing how self-imaging can be done. So Judy Kim has shown 91% of successful imaging rate with a good adherence, and this was also shown in Protocol AK, that is the feasibility study of the DRCR-net. These studies also showed that there is very good accuracy with 91.6% person correlation, and correlation even increases when there is a significant amount of fluid. And the study done by Nancy Holcomb showed that this is actually the first trial for real guided home OCT guided management of the patient, and she was able to show that the interval between injections increased from 8 to 15.3 weeks. So it really has the potential to lower the burden. And there is another study that showed that patients were treated earlier, but sometimes they were actually not treated because of the results of the home OCT. So it really influences decision making. So I think that everyone knows that there is an unmet need for monitoring our patients, and that home monitoring can be an effective way to do that. It does need some support from a monitoring center, and we're very, very excited at the FDA marketing authorization. And just to emphasize that there is a big DRCR-net trial that is going to include 600 patients that will be monitored for a long time, and we'll have finally results if this technology on a long term can improve vision or really lower the burden. Thank you.
You know, and I'll be, because you're going to be leaving, why don't we take questions now on that if anyone has any questions or anything you want to bring up for discussion. Dan, if you have any comments on the DRCR study and such,
Yeah,
I think we'd love to hear everyone's thoughts.
Is Dan here?
All right. I think you answered it. I guess for me, the question of really comes down to with home monitoring. I see all the data that shows me that it's pretty good. Do you think there's a drop off over time with patients? Have you noticed that? Has there been any change? It's really good in the beginning because it's a new toy.
No, so actually it makes sense what you say, because who takes antibiotics for the whole week that he needs to take, right?
Yeah.
But all the studies showed very nice adherence. So probably the patients like it quite a lot, and there is a feedback, so it's nice.
Yeah, I think that's been the data that's been out there. I've been surprised how good the uptake is and how steady it is over time.
Absolutely.
So this will probably come up too. What kind of feedback do the patients get? from the device itself or from anywhere. They don't get any feedback,
No,
right?
but they get feedback from the monitoring center if they're not doing
Correct,
the test
yeah.
or things like that. So.
You wanted to say good job.
Yeah.
Nice work. Nice work.
No, so patients are going to ask, how will I know if I'm doing well or not? And it's going to be a question that'll come up with certain patients. So.
Yeah, but so far from all the longitudinal studies, they are not that long, and we'll know more after the RCRNet protocol study. But so far, they've been pretty adherent with 6 tests a week.
Yeah.
I have a question. And also, it's obvious that using home monitoring is definitely going to extend out the intervals, so it's a good thing for the patients. Do you have any data that indicates that functionally too, that the patients who are monitored this way are better off than those who are coming up? Or
Usha, this is, of course, the most important questions. And unfortunately, until now, we didn't have long-term enough studies. But we're very fortunate to be part of the DRCR network studies, and I think this will give the answer. Yeah, you are very right. This is at the end of the day, it's either better visual acuity or real reduction of burden.
I think you've shown quite convincingly that there's reduction of burden. The question, obviously,
well,
the
reduction of burden
on
reduction of burden on a long term.
Yes.
Right.
Yeah.
Excellent. Great talk. Go ahead and why don't you talk to us now about hypertransmission defects at endpoint and GA.
Yeah, so here I'm even more humbled to give the talk because, you're the Kola Institute with Justice and everyone doing all these studies and the reading center and everything. So I really know much less than all of you on this. And of course, I want to acknowledge Omar Travitsky for his collaboration, and he's working with you guys, with Justice, and so it's really, you know a lot about it. Anyway, so when we are talking about geographic atrophy growth rate, we know that it depends on lesion size and on focality, and it's the size on in visit 2 minus visit 1 area and the time between the visits. And it has been shown by Phil Rosenfeld group many years ago that the square root transformation of the geographic atrophy measurements actually eliminates the differences in size in baseline. And if you use the square root, then you might get more accurate results. But still, it's really dependent on the lesion shape, including focality, because the lesion on the left, one bigger lesion, doesn't have the same perimeter as the 2 smaller lesions on the side. And the group of Lucian de Priori looked at geographic atrophy perimeter as an important factor. And because, the lesions enlarge by growing along their margins. So the larger the margin, the more the lesion can expand. So normalizing for perimeter does have the potential to compensate for having various shapes. All of this has, theoretically it's for every measurement, but it has been talked about with autofluorescence. And the question is autofluorescence still the gold standard at all in measuring geographic atrophy? And we know that in the big studies, in the pivotal trials of the 2 drugs that have been approved, it was, this was the measurement. And the people are also talking about the hyper-autofluorescence around the lesion, and the group of Frank Holtz showed that, for example, in the trickled hyper-autofluorescent, there is a faster progression, and probably there is a lot into it. However, I would like to introduce unfast OCT imaging. We know that geographic atrophy appears bright on unfast OCT due to the choroidal hypertransmission defect, where the RP is lost. And swept sort in a swept source OCT B scan, the sub-RP slab highlights the increased reflected light from the choroid. And actually both spectral domain and swept source OCT can be used to generate unfast OCT. It just depends on closely spaced cross-sectional B scans. And you can have nice imaging. And actually it has been shown that it's nicely correlating with measurements on fundus autofluorescence. Phil Rosenfeld group showed that if the hypertransmission defect is greater than 250 microns, then it tends to be persistent, because sometimes these hypertransmission defects are not persistent. And in this slide, you can see in the second line, which is the important one here, you can see how the hypertransmission defects increases, and actually the drusen are disappearing in this particular case. And in this And in this animation, you can see how these hypertransmission defects grow, coalesce, and become over time geographic atrophy. And you can easily look at it on a long-term follow-up in patients when if you want to go backwards. So just to say that measuring geographic atrophy is still problematic, and we are still not comfortable about it, and maybe fundus autofluorescence is important, but hypertransmission defects can be another way to measure it. And of course, all the work that you guys are doing with EASY, which is a clinical endpoint that can be measured, is also a great potential, and I'm sure that it will be part of the future measurements of geographic atrophy and of trials. Thank you.
So Glenn, do you have a favorite one from a reading center perspective that you think is more feasible?
I think it's been proven that autofluorescence is feasible just because that's been the primary endpoint that's led to registration for the 2 GA drugs that we have. OCT is also very attractive because everybody has it and they're used to doing it. One of the issues with using OCT in a clinical trial is that the imaging area doesn't go out as far as the lesions do often. And so if you want to include the whole lesion, you usually can't do that with OCT. And so hypertransmission's good, but it depends on whether you're looking at intermediate AMD and you're looking for development in the central region as opposed to looking at GA where the lesions may come right up to the...
Where it's already big and growing.
Yeah, and with autofluorescence, we have situations where it's almost exceeding the imaging field. With OCT, it's much more of a problem. The other thing that happens with the hypertransmission, you'd think that it's perfectly easy to tell when you get a hypertransmission, but it can be confounded by basal laminar deposits or debris on Brooks membrane where you think there's not hypertransmission when it's actually atrophy, and you have to check against the B scan. So there's pluses and minuses to both of them.
And the big plus of the autofluorescence is that, first of all, that it was done in the trials, and second, in the pivotal trials, and second, you can show it to the patients easily. So I think that from this point of view, it's an advantage.
I think that's a really good point, especially related to compliance. You talk about how you're going to have somebody get injections in their eyes, for example, for geographic atrophy, and what helps that discussion.
Exactly.
When a patient sees a big black spot on the image and they know that's in their eye and is right next to their fovea, they don't like that. And they also it's the same as home OCT, and I was going to mention this in a little bit, but people like to see their progress, and it's a way of seeing where they are, and it's a very visual thing, so it's I think, very helpful.
Any questions or comments? Excellent. Congratulations on the Pyrone Award. And you have to head off to...
That's why I need to go to the dinner.
That's right. I heard there's a parade also. Thank you for coming, and congratulations.
All right, our next speaker is Dr. Glenn Jaffe, who's at Duke University. He's the head of the retina section there and also the head of the Duke Reading Center. And he's going to be talking about imaging AI in clinical trials.
So Anat actually did a good lead-in, and one of the things I was going to mention was the home OCT. But first, I'd like to just acknowledge my disclosures. I've consulted for companies as listed below that are potentially relevant to the discussion. So the first question is there really a role for AI in clinical trials? You've been hearing, I just mentioned using autofluorescence. That was all done semi-automatically or manually. And can we even use AI in clinical trials? And I think the answer is yes, and it's going to be yes even more in the future. So we can use it for automatic image quality assessment. If you're in a clinical trial and you don't like sending an image in, then waiting around, finding out that the image quality wasn't good enough to get graded in the trial, there's the potential to get immediate feedback on the image quality with AI. It can help with eligibility assessments as well. As a reading center, we'd like to get things turned around very quickly, and it can help to measure lesions quickly, and we can grade more efficiently, as I'll show you, and it can now, we have the possibility of doing it for endpoint analysis. So I'm going to show you 3 examples of how AI could be used in a clinical trial, and I'm going to use the example of MacTel. I'm going to use the example of GA, and I actually chose a type of AI with GA to complement Justice's proposed talk, so I'm not going to talk about ellipsoid zone. I could have talked about that in the context of geographic atrophy, but I will talk about it in the context of MacTel. And also for neovascular AMD, you just heard the potential use for AI in a trial of neovascular AMD with fluid monitoring. So just recently, ellipsoid zone loss became an approvable endpoint for clinical trials. And so the FDA has said that if you have complete ellipsoid zone loss, that is an approvable endpoint. And you can use potentially AI to get at that endpoint as long as there is some manual oversight of the AI. You can't just, at least currently, use automatic segmentation without manual oversight. But some of you may be familiar with the CNTF trial, the ciliary neurotrophic trial. These are 2 phase 3 trials for macular telangiectasia type 2. This is a neurotrophin that's encapsulated in an implant that releases medicine via genetically engineered cells. They're genetically engineered RPE cells that are designed to overproduce a protein of interest, in this case CNTF. And the idea is to try and prevent the ellipsoid zone loss that you get in macular telangiectasia. The MacTel zone is that area just temporal to the fovea, and it progressively enlarges and then can cause decreased vision, can cause scotomas, and decrease in activities of daily living. So these 2 phase 3 trials used ellipsoid zone loss as the primary study endpoint. And we did manual grading or semi-automatic grading at the reading center for these 2 trials. Very labor intensive to be able to identify the ellipsoid zone on each of the scans in a volume scan. And we really would like a more efficient grading process. And so this was an initiative that was led by a brilliant graduate student now out and making a lot more money than her mentor, actually, Jessica Liu, who had worked on a method, a deep learning method for automatically segmenting the ellipsoid zone defects in MacTel type 2. And her mentor is Sina Farsiu, as you see on the right, and I was also involved in the study. It used a novel method to do the AI, and this is she called it DocTAD, which is a Duke OCT analysis method, and it's a convolutional neural network, and instead of a single B scan, it's a cluster of 5 B scans, so you're getting a volume, and the idea is that when you're looking at these things, it's taking advantage of the fact that when you have an ellipsoid zone defect, typically there's a defect at the neighbor, or there may not be a defect at the neighbor, but you want to, when we're doing grading at the reading center, we actually look at the adjacent scans on these borderline cases. So you're taking advantage of these volumes, and then running that through a neural network. And this is the kind of thing that you get. You get a map that is actually a prediction map, but it looks just like an ellipsoid zone defect map. And we looked at the performance of this algorithm compared to a couple other ones that we've also used at Duke. And so first of all, the manual grading is considered the gold standard. And if you look at the areas, the average area measured by manually, it was 0.84, measured by that DocTAD method, 0.87 millimeters squared. If you want to look at the performance of the algorithm, we were using the dice similarity coefficient, or the dice score. And this is taking into account the true positives, the false positives, the false negatives in a formula. Scores closer, 1 is the highest you can get, and scores above 0.8, 0.85 are very good. And you can see that the dice score was pretty pitiful for the DocTrap model, for the CNN model, 0.05 or 0.52. It was 0.86 for the DocTAD model. And then the question is, if you use this model, can you actually replicate the clinical trial results? And so this just gives you an example also how you can improve by doing longitudinal transfer learning, where you take the image, the preceding image, to help train the next one to train the next one for a given patient. And these blue and red spots on that image are the false positives and false negatives, or false negatives and false positives for red and blue respectively. And you can see that as you go on, these blue and red spots start going away because the algorithm becomes more accurate. So we applied these to the phase 2 trial. It turned out the phase 2 trial was positive. It showed a difference in the CNTF treated group and the control group. And now actually in the phase 3 trials, both paired phase 3 trials are positive, showed statistically significant difference, which was the endpoint for the trial, and it's now sitting at the FDA to see if it gets approved. But we did the manual measurements, and then we did the automatic measurements, and it turned out that the difference was actually slightly greater with the automatic measurements when you compare the treatment to the control group, but it replicated the clinical trial results. So we could have saved a whole lot of work had we done that automated assessment. What about doing AI for GA? You can certainly do it for ellipsoid zone loss, and that is now an approvable endpoint, and just as has been done in COAL, we've also developed an in-house ellipsoid zone area measurement. But I want to show you a different way of using the AI for a GA trial. So this is in the GATHER1 study. As you all know, this was for avacincaptad-pegol to treat geographic atrophy, and if you look at the treatment group compared to the sham group, about a 27% difference in GATHER1. And so then the question is, can you use AI, and could we have replicated it and also saved a lot of work? So we gathered the GATHER1 data, and we developed an AI algorithm. In this case, it was to do automatic fundus autofluorescence assessment. And the idea is that not only could you potentially use this in a clinical trial, but if you could use this in the clinic and just press a button and get the measurement, that would be very nice. So we did this for automatic autofluorescence segmentation and trained this on 1,468 semi-automatic segmentations, 205 subjects, 410 eyes. We did 10-fold cross-validation. The idea here is that we want independence of the training, the validation, and the test sets. And again, the DICE score was very high, 0.92, sensitivity was 0.99, the specificity was 0.92, and when you look at the correlation between automatic and manual geographic atrophy measurements, very high. And we then applied that to the clinical data and showed a 36% reduction compared to sham, highly statistically significant. So again, the AI replicated the clinical trial results when we used these tedious manual measurements. Another way of doing this, and Anat alluded to this, this is a different method of using optical attenuation and looking at the attenuation of the signal penetrating into the choroid, and you can do that to measure GA area, another way to do it. It hasn't really been fully validated yet, but it is an optional, another alternative for measuring the area of these lesions. And I'm just going to very briefly touch on this because Anat already mentioned this, but I just want to, this is the AI for neovascular AMD. You can use it in the clinic. It was just approved by the FDA, but at least theoretically could also use it in clinical trials to monitor fluid. And the idea is monitoring the volume trajectories. And I just wanted to clearly mention some of the advantages and the disadvantages. Obviously, we talked about decreased office visits, and we can better understand the neovascular AMD fluid dynamics. The notifications potentially are time consuming for the physician who has to answer all of these notifications. And you can set the threshold, and you can imagine people setting the threshold such that they're not going to get notified very often. And then that kind of defeats the purpose. It also requires patient compliance, and we talked about that as well. Patients do like to see real-time results. We know that they're compliant for a few months anyways in these trials, but I suspect that they'll be continually motivated to do this, especially if they're having to come in less frequently. So again, the take-home message is that I think it is a valuable tool in clinical trials. It's going to be more valuable as we develop and validate these. And it's going to help us a lot for evaluating image quality as a clinical site. I think it's going to help you because you'll get automatic feedback on the quality of your images without even having to wait for a person to give you feedback from the reading center. And it helps in eligibility screening. May also give you immediate feedback on whether a patient may be eligible or not, which would save also time. And it helps us for grading and reduces the clinical trial costs. So thank you very much.
Glenn, why don't you stay up there? We'll ask questions right now since we're in this mode. Any questions or comments? One of the things I think you pointed out, I think where AI, we've seen it at the research lab, is just making us more efficient from image analysis. So do you foresee that, the analysis you did in Gather, do you foresee doing actually manual segmentation? Do you think the FDA will allow you to do AI-based measurements only?
We're not at the point where they'll allow us to do AI only without any manual oversight, but I can tell you, as an example, we've applied the GA measurements by autofluorescence to a couple of different data sets from different clinical trials now. And I do a lot of arbitration on these images from the primary readers and assess the images, which is pretty tedious. And I've looked at we get on-phos images of the GA area on the autofluorescent images, and they're kind of amazing. And especially we've been using a hybrid where we do manual we train the whole algorithm. For the first visit, we do a manual assessment to have a, quote, gold standard for the first visit, and then use the AI subsequently. And the oversight is very quick. It's a lot faster than potentially having to manually outline an area. So I think it is a big savings. Even if we have to do manual checking of the AI, if the algorithm is good enough, you don't have to do much manual correction.
Yeah.
So I'll ask you a follow-up to that, because the FDA has set forward specific parameters for AI-based algorithms for clinical approval. This is different. You're using it in a clinical trial setting for grading. What would you have to do to get this validated and accepted as a primary measure?
Without manual oversight, you
Yeah.
mean? It would take a lot of validation. And one of the issues that you could imagine when you do develop an AI algorithm, to have it truly validated, it can't be just valid for that one data set. Mm-hmm. It couldn't just be valid for Gather 1. It couldn't be just validated for OAKS. You have to have it generalizable so that you'd be getting similar results when you apply them to data from different data sets. And so I think the key thing is being able not only to demonstrate the performance of the algorithm in general, like I was showing you, but also to show that it's generalizable across populations and data sets.
Agree. Any other comments or questions for Glenn? Okay, thank you, Glenn.
All right. So our next speaker is Basil Williams. He's at University of Miami, and he's going to give us an update in imaging for ocular oncology.
All right, so what's new in ocular oncology from an imaging standpoint? Really, there's some old technologies that can be used in new kind of ways, and I'll highlight those. So these are my financial disclosures, which are not relevant. And I want to talk about annular array and ultrasound. I want to thank Dr. Yale Fisher, who taught me how to do ultrasounds as a resident and really taught me the value of annular array in ultrasound technology. So this is most useful for evaluating the ocular wall, the anterior orbit, and for measuring lesions. And basically, what you can do is you can adjust the depth of focus. So if you cut the cap off of the ultrasound, you can see that there are 5 different rings that are assessing different levels of depth on the ultrasound technology. And this has been done for decades in regular ultrasound, but in ophthalmology has only really been around for about the past 10 to 15 years. And here you can see the first paper on it by Dr. Silverman's group at Columbia. And so basically we have a number of transducers of different frequencies, and we use the 20 megahertz transducer for this, and you can set it to the vitreous, the retina, or the orbit, and I'll kind of highlight some cases. But basically what happens is you can move the ultrasound to focus on different areas. So here's an ultrasound of a person with asteroid hyalosis, and you can see as you change focus how clear it is of where you're looking. So you can see in the orbit the normal vasculature and the movement there versus when you're focusing on the vitreous, and things light up nicely. Here is an example of a case that was described by Spade and Yale Fisher that we often would say as central serous choroidopathy, but you can actually see on ultrasound of this resolution how thick the sclera is, and that's actually impeding the blood flow from kind of leaving the sclera and causing some increased thickness and sometimes subretinal fluid. Here's a retinal detachment, and you can just see the posterior hyaloid nicely with blood posterior to that, and then the blood moving around anterior in the liquefied vitreous. You can see an operculum very clearly, and if you pay attention to the retina, you can even see where the operculum broke off from. Here, you can actually make the diagnosis of what's going on with this patient by ultrasound alone. You have a dense vitreous material with perhaps some membranes, and you even have some hyperreflective areas suggestive of silicone oil. In fact, this is a person post-bevacizumab injection with endophthalmitis, and you can see the oil from the droplets from the injection. Here, a retinal tear attached to the posterior hyaloid, and this is particularly relevant in comparison to this case where you can see a tear there, and you can actually see that that tear is protected by the scleral buckle at the superior part of the image, and you can tell that there's a buckle because you can't see any of the normal orbital vasculature behind it, which you can see in the inferior part of the image. And so that's helpful if you have a person with a hemorrhage and you need to understand where the pathology is. This is a patient with a central retinal artery occlusion, and you can actually see the emboli there in the optic nerve. And so if you focus deeper, you can identify that. And the ultrasound technology allows you for good measurements of this kind of stuff. So here is a suspicious lesion, an indeterminate lesion, and you can see the quality of the scan. So you can actually measure from the posterior portion of the retina to the anterior portion of the sclera to get really accurate measurements. Now, obviously, the gain is turned down here, so you can identify the lesion a little bit better, but it really is quite helpful. How about in this case of a melanoma with an inferior exudative detachment? You can actually see the spontaneous pulsations extremely well, letting you know that there's intrinsic vascularization and kind of helping to confirm the diagnosis of melanoma. Here you have a patient with hemorrhagic choroidals, and you can see the blood in the vitreous moving nicely, and you can see the retina overlying the choroidals. What's actually helpful here on dynamic ultrasound is you can see that you don't have mobile blood in the choroidals, and so if you try and drain at this point, it'll actually be harder to drain. Here's a patient shared also from Dr. Fisher. They've seen in 2017 and 2022. You can see a little bit of a difference in the background color there, but the patient was complaining about a new headache, and so an ultrasound was performed to see if there was any possibility of posterior scleritis, and what you can actually see here is an AV malformation with a CC fistula. If you look at the inferior ophthalmic vein, you can see pulsation, and you're not supposed to have a heartbeat in the venous system. You can also, it's important to know that not all orbital tumors have intrinsic vascularity, but again, you can outline the tumor very, very well. So this technology is really, really helpful. It's less sensitive outside of the focal plane. It requires a significant amount of ultrasound experience and requires software adaptation. I must admit, we had this technology in our clinic for some time, but our ultrasonographers were using the old 15 megahertz probe without the annular array because they didn't know how to use the software. So it can be really, really helpful to focus on that. And then I just want to highlight really quickly, transillumination is something that has been used for uveal melanoma for a long time. Most people that have TI probes really have the old probes, and we had it like taped up with a bunch of duct tape, which really didn't look great to the patients. And so I was fortunate enough to collaborate with Vortex to kind of work on this new transilluminator. So a couple things in the oncology world, when we think about a focal cataract and sentinel vessels, we really want to do transillumination because there can be a tumor that's hidden behind, and you can see here on the UBM and ultrasound. And you can just use that with a fin-off light in your clinic. Here's an example of a patient that underwent a vitrectomy for a non-clearing vitreous hemorrhage for presumed peripheral exudative hemorrhagic chorioretinopathy. After multiple surgeries, you can see significant pigmentation in an anterior pigmented lesion. Here's the ultrasound. You can see not with annular array, but there is extraocular extension. And this is actually the picture anteriorly. After multiple vitrectomies, the tumor actually was extending outside the eye. So it would have been really helpful to do transillumination in this case to prevent the enucleation, which was happened unfortunately too late, where the patient had metastases and ultimately passed away. So it can really be helpful when you can't see what's going on posteriorly. Transillumination here you can see in our regular techniques leading us to how we perform our biopsies. Unfortunately, though, transillumination can be misleading in some situations. Here's a video from Arun Singh's team, and you can actually see when you have a mushroom-shaped lesion, as you move your light source, the shadow cast can be a little bit difficult to identify where the tumor is. But the darker area that's more anterior is actually the base of the tumor. And then one last thing, I just found this out recently. Dan Miller in Cincinnati is using the transilluminator for PDS refills, so that way you can actually highlight very well where you need to do the injection. I'm fortunate enough to not have presbyopia at the moment, but I think this is probably additionally helpful if that is the scenario. So just in conclusion, annular array, it has a movable focus. You get better image quality and resolution, but it does require experience. And then transillumination can be really helpful, but it can cast an inaccurate shadow in some scenarios. Thank you.
Questions from the audience or the panel? I'll ask what we're in. So, you mentioned it takes a little bit of experience to do it. You're experienced. How easy is it to do annular array with this probe?
Yeah, I think it's actually fairly easy once you know what you're looking for. If you set things on the retinal or choroidal setting, you actually get fantastic images there. You can play with the gain a little bit. And actually on this ultrasound, you do have some availability to adjust some of the settings. You can actually get decent ultrasound through silicone oil, which is something that we haven't been able to do. And obviously that's great in all situations with retina, but particularly in patients with tumors, if you put in oil for whatever reason, you can now still kind of get a general idea of the size of tumors as well. So the learning curve isn't that bad for actually using the ultrasound. It's more for the software.
I gotcha. Is it? And are you doing your own imaging or ultrasounds, or do you have an ultrasonographer to yours?
We have an ultrasonographer. However, they're on a different floor than I am, so it depends on how backed up clinic is. If clinic is really backed up, then the patient can wait downstairs. If clinic is moving quickly, then I bring them upstairs to my clinic, and I use that as an educational opportunity for the residents.
I have a question. That was fascinating talk. It's not something that we routinely do in our clinics, as it's routine, the retina type of work that I would have been involved in. Yes, ultrasound is something we use when we see tumor. How frequently would it be your primary imaging modality, or is it just, for instance, we would just do color imaging and then fluorescein angiography or OCTA to diagnose a lot of the cases that you showed. So where is it that you really find its strengths?
Yeah, so obviously in a number of the cases that I showed, you can identify the retinal tears on clinical exam. You're seeing the endophthalmitis on clinical exam, and it was more just some cool images for the presentation. But for the choroidal hemorrhage, I do think it's actually helpful to tell when you should go into the operating room. Obviously for larger tumors to measure them, smaller tumors to measure them and follow over time, larger tumors so you can assess how much radiation is required. In situations of artery occlusion, I think it's actually nice to look at the embolus and you can send the patient out quickly. So I think it does have some practical applications in the retinal world as well.
Awesome.
Yeah, I was just going to make a really quick comment about the transillumination for the PDS. It's nice not, regardless of whether you're presbyopic or not, one of the things that it's useful for is that some of you are probably familiar with the dislocation or dislodgement of the septum into the reservoir that happened that put a stop to the PDS until they reconfigured it. And one of the reasons that happened is that it was difficult in many cases to identify the septum because there was fibrosis over the septum. And with the transillumination, you can actually see the septum through the fibrosis when it occurs. You also can get scleral discoloration, a grayish appearance adjacent to the flange, and for a while we weren't sure what it was, but with transillumination it's very clear that it's an area of scleral thinning, and you can monitor that over time as well.
Excellent. And I'll just say duct tape on an instrument does not make patients scary. It makes them feel it's a well-used machine. That's a nice job.
All right. Our next speaker is Alexandra Rachiskaya, who is at Cleveland Clinic at Cole Eye Institute, and she's going to be talking on intraoperative imaging from IOCT to IFA.
Good evening. So I'm going to take you to the OR, and these are my financial disclosures. So we're going to talk about intraoperative OCT and intraoperative FA. So and at our institution and at other institutions such as Duke, there's been a lot of work looking at intraoperative OCT. And the problem is that it's really hard to find outcomes. Vision outcomes, anatomic outcomes, or aura outcomes in terms of decision-making or efficiency of surgery. So I'm going to share with you some of my cases where I found that the OCT was extremely valuable. So this is a case of retinoschisis retinal detachment. And what we see here, there's a bullous rhegmatogenous component, and superiorly, you have this large outer retinal hole. And sometimes it's extremely hard to find inner retinal break. So you can see beautifully this thin inner retina, there's outer retinal hole pulled up, and then on OCT, we're able to identify this inner retinal break very nicely, because sometimes on visualization, it's hard to see because it's so thin there, and you think there's a break and there might not be one. So identifying this break was was really a game changer for this type of surgery, because then we can mark the break and use it to drain the fluid. So we're using PFO here, the retina is flattening. The other goal you have to achieve is to bring two of the cavities together, so you collapse both subretinal fluid and the schisis, and as you saw on that OCT image, we could confirm that both of the cavities are flat. And we finished the case by doing laser, and we lasered both the outer retinal hole and then the inner retinal defect. In this case, we did buccal as well, and we ended up using C3F8 gas. And we continue seeing how nicely everything looks, and the patient did great. And you can see postoperatively the macula OCT looks fantastic. And then as we go out peripherally, you can see how everything is flat, including the outer hole and thin inner retina, and you can see the laser that we have administered. Now, it's not always so simple. So this is another case. Somehow I attract this retinoschisis, retinal detachment, which are not very common. But this is another case, and you can see on the imaging, we were convinced that's where the inner retinal defect was. But when we imaged, we actually see that the retina is just extremely thin there, and in fact, it's intact. So it's not where you want to drain from and create another break. And we found another location that explained this rhegmatogenous retinal detachment in the case of retinoschisis. So gene therapy, there's more and more gene therapy that's being done. This is gene therapy for inherited retinal diseases, X-linked RP. And here we're treating submacularly. So when it comes to neovascular AMD, for instance, you treat peripheral, but the stakes are much higher as you're going submacularly. And you can see here, we use intraoperative OCT to confirm that we're in fact under the retina and there is no damage to the underlying RPE, and we see propagation of the bleb. And as the bleb gets bigger, we want to make sure that we're not causing any damage in the foveal area. You see how large this bleb is because it's supposed to go from the arcade to the arcade to treat all the areas that are identified on microperimetry. And we see inversion of the foveal pit, but no macular hole formation. Now, this is another case, and this is a still of intraoperative OCT, and you can see that outer retinal change, and that's where I started the injection. And we kept going, and then in this case, so you do this is all studies, so it's protocol driven, and you're supposed to administer a particular amount. So as we were counting down how much we've given, we were supposed to give more. So we kept going, and as we kept going, I saw that type of change right there in the fovea, and you can see the outer retinal change. So I made a decision to stop, and I was very concerned because I wasn't sure exactly what has happened. And so you can see here, this is the patient pre-op, and then there's the change that we saw intra-op, and then post-op, they do beautifully. This is less than a week OCT, and you can see that everything is restored. But I think using intraoperative OCT, we're also learning in terms of outcomes, if it's really related to the drug or potentially related to surgical manipulation of the tissue. This is another case where I found that intraoperative OCT was extremely helpful. It's an optic nerve pit. This is a gentleman who came for a second opinion. He's had 3 surgeries previously done with recurrent optic nerve pit. He's had ILM peel, he had subretinal fluid drainage, and laser. As you can see here, there's a large area of subretinal fluid, and you can see the other pockets where fluid used to be previously, and we can see the pit. So the decision was made to take this patient to surgery and to use the amniotic membrane graft. So here we prepare the amniotic membrane, and then we position it in the pit using bimanual technique. And so it's very important that it's well positioned. And the OCT is very helpful here for me because it allows me to visualize that I placed it in the right spot. So you can see the position. Oh, thank you. the position here, and it's very well positioned. But then you have the tricky part of doing air-fluid exchange, and you don't want that amniotic membrane now moving. So you can see I'm going a little bit more nasal than usual, trying to go slowly and make sure that it stays in place. And I can image through air and confirm that it's still exactly where I left it, and I don't have to do any more manipulation in this eye. And you can see post-op outcome, the patient did great, and I love this picture of the amniotic membrane sitting there. So what about intraoperative FA? This is a new technology that's getting some attention, and there's some publications on the technique, but once again, it remains to be seen how it actually helps us in surgery. So as you all know, when we do FA in clinic, there's light wavelengths that creates excitation, and then there's emission of the wavelengths. So how is it done? What we have, when you look, so I utilize Alcon Constellation Vision System, and you have the area of the accessory light source, and you place an 485 nanometer bandpass filter in that area. And so that creates your exciter source. And you use the light pipe endoilluminator or a chandelier in that accessory light source. And then initially when this was done, you would then put the 535 nanometers bandpass filter in the blank slot of a switchable laser filter to produce your barrier filter. But if you use such a visualization as Ingenuity, you can actually, instead of using the physical filter, you create a specific color channel that serves as a digital barrier filter. So I'll give you an example of this patient. This is the patient who is monocular, and she came in, she's a diabetic patient who developed a macular hole. So I took her to surgery, and I utilized both intraoperative OCT and intraoperative FA in this situation. So we can see here that as we peel, she has a combined ERM and ILM, and a lot of ERM right at the edge of the hole because you can see the negative staining. So this is a monocular patient, and we want to make sure that we minimize any toxicity, that we peel very safely. And I can actually see on my 3D viewing screen the OCT, and I can see there is a little bit of a tulip formation, but there is no area of traction. And here's the fluorescein angiography that gets administered through IV, and you can see how it starts lighting up, and it gives me areas of non-perfusion. It gives me an idea of where NVE might be, because in this patient, I would like to use fluorescein angiography to guide me how much additional laser she needs. This is a monocular patient, so it's a fine line. I want to make sure I preserve as much central retina, but yet treat her well. So I found this useful in this particular situation. And you can see centrally, and you can also move and see peripheral pathology as needed. So as I mentioned, there's a lot more technology coming to the OR near you, but the question is, what kind of outcomes can we look at, and also how does it affect your surgical decision-making and how it affects the efficiency in your operating room. And I would like to thank all my fellows and colleagues and OR staff that put up with all the things I make them do extra, and I thank you for your attention.
Great talk, Alexandra. Any questions or comments from the panel or in the audience?
Just a very brief comment. It was a great talk. As far as the gene therapy goes, a little bit down the road, in addition to showing the integrity of the retinas you did, Leila Bajzovic has been working on actually quantifying the bleb size so that you can make sure you're delivering the amount that you want in the volume that you want. And so that is also a potential application for AI.
Yeah, it's absolutely, this is a fantastic point, because what happens is as you inject, you're reading off the syringe how much you inject, but there's some loss potentially in the vitreous. As you approach the retina, you start injecting as you approach, and there might be some reflux. So it's hard to measure actually exactly how much has been administered. So Leila has done fantastic work in that realm. There's a question?
During the human X-linked RPG are probably the photoreceptors, and unless they're really degenerating, they might be still retaining their normal shape. So was there any attempt to do adaptive optics pre and post-operatively to see?
So in terms of adaptive optics, so adaptive optics is not part of the protocol required imaging. We do microperimetry, trying to see the areas that are affected. And you're exactly right. It's a fine line because there's nothing to save in the periphery. You need to target exactly where the disease is, and so that's why it's submacular. And there's discussion that's been even at the main meeting about some changes that we see in the macula after some gene therapy. So I think it's, to your point, there's so much unknown, and adaptive optics might play a role in the future. But that's a great question.
Awesome. Thank you, Alexandra.
Great. Next speaker is Dr. Daniel Martin, who's the chair of the Cole Eye Institute and also the chair of the DRCR network. And he's going to be talking about important imaging questions in the current DRCR retina network studies.
Thank you, Sumit. So I was assigned this topic by Dr. Shrivastava and Dr. Sharma. And I didn't really have this talk. And I sort of got lazy, and I called Sunil and said, nah, I'm just going to do something else. But as is true, Sunil always makes me better. He has been working with me for 20 years to make me better, and I'm making progress. Anyway, what I'm going to do is I'm going to talk about some of the imaging questions that we're trying to address in the current DRCR Retina Network studies. I have no financial interest to disclose. I always start with these slides. I know everyone here knows about the network, but just very briefly, 2002, we started as a diabetes entity. In 2017, we expanded to all retinal diseases. 2019, we renamed ourselves. We are now the DRCR Retina Network. And we've done 38 multi-center clinical trials at 160 clinical sites with 120 publications. This is our structure. I have the incredible privilege of serving as the chair with Jenny Sun. We have lots of completed protocols. These are the list of the current protocols that we're doing, all the ones in green. We're doing more protocols than we've ever done before. And within that group, I sort of look through, and when you look at everything if you look at all of the imaging questions in our existing trials, there's a lot. So the first one has already been covered by Anat, and I'm not going to spend a huge amount of time with this, but it is the fundamental question. I mean, HomoCT has tremendous appeal on many levels. It gives us a lot of information that I think when you see it, you're going to want it. But the real question is, does it make a difference? Can daily imaging with HomoCT reduce the visit and treatment burden and at least maintain or improve visual acuity outcomes? In order to get this paid for, one of those two things has to happen. This is the trial design. It's 600 eyes, newly diagnosed neovascular AMD, randomly assigned to treat and extend versus HomoCT guided treatment. We have co-primaries, which is superior comparison of mean change in visual acuity and number of injections from baseline to 104 weeks. The study is being done with faricimab as the primary anti-VEGF agent. We did a planning study called Protocol AK, where we enrolled a number of patients with neovascular AMD, and these are the fluid curves, composite graph of all the curves from those patients. And as you can see, it's all over the map. And when you go case by case, I think Anat may have done some of this already, you see this tremendous diversity of how people respond. And we've already learned a lot from this, from an imaging standpoint. For example, there's little fluctuations. The question is how much of that is noise and how much of it's real. When you go back and correlate that with the OCTs, it's real. The RPE does its job. Small amounts of fluid come and go all the time. You just don't know it because you're only looking once a month, once every 2 months. But if you look on a daily basis, it's little bits that appear and little bits that go away. The RPE works. I'm going to skip through this. The second question is there a role for OCTA in eyes with high-risk dry AMD? Specifically, is it important to identify non-exudative CNV? So we've been trying to find a role for OCTA for a while. In diabetic retinopathy, we've included in a number of our studies. And it's amazing how, first of all, how bad a lot of the images are and how many of them are just a Rorschach test. And quite frankly, as many as 40% of the images we receive in the network are unusable. So we decided to look at this in protocol AO in neovascular AMD specifically to look at. There seems to be this transition for some patients where they go from dry AMD to non-exudative CNV to exudative CNV. There's been a lot written about that in recent years, but there's not been a prospective study on the scale of what we'll be doing here. We anticipate we'll have a lot of eyes to look at. 600 eyes are coming into protocol AO based on CAT and other studies. Probably about 3/4 will have unilateral disease, and therefore we'll be able to look at the fellow eye. We know that the risk of exudative disease is about 10% per year, and so there should be a number of events to look at. And specifically in this ancillary study, we'll be describing the incidence, prevalence, and natural history of non-exudative CNV and compare the time to diagnosis of exudative CNV, visual acuity diagnosis and vision and imaging outcomes. The third one is in protocol AL. This is the network's ventured into the oncology world, and specifically we're going to look at can sequential multimodal imaging, wide field fluorescein angiography every 3 months, for example, help us understand and predict the development of progression of radiation retinopathy. In addition, we'll also look at the questions of whether or not long-term steroids, such as Iluvien, or long-term anti-VEGF delivery with faricimab, will that be result in any difference in the incidence of, say, non-perfusion and other components of a radiation retinopathy? The fourth question is in protocol AM. This is our epiretinal membrane study looking at the question of in eyes with epiretinal membrane to good visual acuity. Should we be thinking about doing a vitrectomy in those eyes, or should we observe those eyes? We'll also be looking at, are there imaging biomarkers that can predict visual acuity outcomes when surgery is performed, and who will progress when surgery is deferred? This is the design for protocol AM, 400 eyes with good vision, 20/25 or better, epiretinal, but significant involvement of the central of the central subfield, significant involvement of the center of the fovea from the epiretinal membrane. And many of these eyes, you look at the OCT and you can't imagine that they're 20/25, but when you do an ETDRS protocol refracted vision, actually, many of the eyes that you operate on today that you think are 20/40, 20/50, they're really not. If we just refracted, which retina people never do, you'd be surprised how good the vision is in many of these eyes. So this is going to be a way to kind of level that playing field to answer the question, should we be operating in these eyes? And are there predictors? We're going to do an AI analysis looking at the OCTs over time to see if we can identify variables that would predict outcomes in those who have surgery and those who progress and who do not have surgery. And then the fifth one is protocol AI. By the way, in case you hadn't noticed, we try to preserve our numbers. We try our letters. AI is obvious. AO for OCT, AM for membrane. So we've reserved protocol AI for a while, knowing this wouldn't just be a single protocol. It's going to be the where we sort of list, where we compile all of our AI collaborations, and we have a lot of them. Why? Because we have a ton of images. If you think about what you need to do good work in this area, what do you need? You need lots of images, but most importantly, what you really need, and we have a lot over time, what you really need is not only the images, but you need rigorous phenotyping of study participants, the longitudinal data sets, and the outcomes, well-characterized outcomes. So at present, we're currently working with multiple groups. We have 9 different collaborations ongoing in diabetic retinopathy AMD. These are the institutes with whom we are collaborating. I'm not going to go through the list of all these things, but just to give you an idea of the stuff that we're looking at. Some of it is what you might, or our prediction of treatment responses, but some of them are really pretty cool, such as basically, where is it? And the last one, generating synthetic OCT blood vessel maps using fundus images and fluorescein angiography. So in summary, the network has a number of imaging studies that are ongoing as part of our large clinical trials. that should help us determine the optimal management of neovascular AMD, the role of OCTA in AMD, the development and progression of radiation retinopathy, identification of biomarkers for optimal management of eyes with epiretinal membrane and good visual acuity, and the use of AI in diabetic retinopathy and AMD. Happy to take any questions.
And on time. That was a great talk. You did a good job. I'm glad you.
I did it just for you.
Nice. Thank you. I appreciate that. Since you did such a great talk, how about some questions for Dr. Martin? I'll start. With all the images that you've created and the AI and specific that you're talking about, you've done this over years, right? And so you said it, you hinted at it. What's the image quality truly like in the images that you're gathering from 160 different centers?
Yeah. So it is variable, but first of all, the beauty of having a reading center such as the one Glenn Jaffe runs, he can probably speak to this better than me regarding image quality. But we spent a lot of time trying to improve that over time. Thank God SDOCT has been around as long as it has, because the problem with CAT was that CAT was done with time domain. So there's a lot of stuff we never could do. Glenn, you want to comment on that?
Yeah, that is very true. When OCT first came in, there was actually a pretty steep learning curve, and you don't think about it because now it's basically one of our ocular vital signs, and you do it on everybody. And the image quality for OCT is quite good. As you said, the image quality for OCTA is quite bad, and even with highly trained people, you still get imaging artifacts that are not just technical problems. It's just a function of the systems, and so we get the same thing, that with OCTA, 30 to 40% of them are unusable, and it's because of projection artifacts or motion artifacts or just the standard or other types of technical artifacts. So that is a challenge. And the other thing I've noticed over the years is that photographers are not as good as they used to be, both for fluorescein angiography and color fundus photography. They used to be trained ophthalmic photographers that would go to ophthalmic photography school and get a degree, and now they're technicians in the clinic that are sort of learning on the fly, and so we're having to dumb down the imaging protocols. But it's also, I think the imaging capabilities are better now. So for ultra-wide field imaging is less technically demanding and allows us to get wider field images and better quality images. 7-field imaging for diabetic retinopathy is pretty much going away because the image quality is so bad.
Yeah.
Yep.
Any comments? Nice job, Dr. Martin. You should keep making new talks. Next up is Sumit Sharma. Sumit's going to talk to us about imaging and uveitis. Take it away, sir.
Great, thank you. So my financial disclosures are as listed, and a few of them are relevant to this talk. But we know that uveitis can be really challenging, and 1/4 to 1/3 of all patients will lose vision because of uveitis. And our best therapeutics aren't that great. They have a lot of systemic and local side effects, and at best only control about 2/3 of our patients. And the grading systems that we use, at best, are average. They're ordinal. They were originally made as a descriptive tool. And the agreement between the same grade, between different graders, or even between the same grader at multiple times is very poor. So most trials, though, in uveitis use these ordinal scales as an outcome measure, and most trials are either really slow to enroll or fail because of imperfect subjective measures of activity. And identifying low levels of activity still remains a challenge, and really having a continuous measure of inflammation would allow for more precise measurements of activity. And that continuous measure is probably not one measure. It's probably multiple different measures depending on the specific type of uveitis. So our goal over the last 10 to 15 years has been to develop use our imaging devices to quantify inflammation using software that we've developed that automatically grades the amount of inflammation in a continuous scale, and have it be both reliable and reproducible, and then be able to use it with machines that we already have. And so we've shown this data before, where we can take a scan of the anterior chamber, quantify the number of anterior chamber cells, and use that to generate a score of the inflammation in the anterior chamber. It's very highly correlated with clinical exam. We've published on that. It identifies cells even at low clinical grades. And in animal models, we've shown that the cells that we're picking up on OCT are actually inflammatory cells, and we've done reliability and reproducibility experiments as well. And so we have a fast tool that measures and quantifies anterior segment inflammation. And we can use it in cataract surgery patients. We've done work there in red eye, in screening, and now we're actually using it as an exploratory endpoint in different clinical trials. So Dovetail was a phase 1 multiple ascending dose open label treatment study where patients got 3 different doses at baseline week 4 and week 8 of 3 different doses of vamikibart, which is an anti-IL-6 antibody. And as part of that, we did an exploratory analysis of what's actually happening based on either clinical grading on the left, and you can see at baseline there's about half the patients that don't have any cells, but half of them do, and the clinical grades are as listed. And then at day 84, that clinical grade goes down, and this is the clinicians don't see the imaging at all. Versus on the right, this was the automated imaging that was done at both baseline and day 84. And it's interesting, we don't really see a change in the AC cell score. We wouldn't expect to with an anti-IL-6 intravitreal therapy. And so it's interesting to see the dichotomy there, and it's unclear what's causing that dichotomy. Is the automated number correct, or is the clinician grade correct? This is the same thing shown in a slightly different way. So we have anterior chamber cell density on the y-axis, and on the x-axis, the clinical grade at 4 different time points at baseline, day 42, day 84, and day 140. And we can see that the cell counts don't really significantly change, but the clinical grade is coming down over time. And so it's just really interesting. I don't think we understand it yet, but I think it's giving us some interesting information there. We can also get retinal vascular leakage measurements on wide field fluorescein angiography and OCT segmentation and fluid calculation. These are things that we've shown are very reliable and reproducible. We can get a total retinal leakage index. You can see the difference between the 2 images where it's 6% versus 9%. And we've looked at this, and can you determine if an eye is active or inactive? And the answer is yes. You can say activity or inactivity just based on the fluorescein angiogram. And then we've shown, and you've seen some other measurements of the intraretinal fluid volume analysis and getting an overall retinal fluid volume and EZ data. And so what we have now is a multiple ways of getting a continuous measure of active inflammation. And so we wanted to look at these tools all together instead of just looking at them individually. And so we did a study, the prospective study, the imaging quantification of inflammation study, just single center at the Cleveland Clinic, where patients in phase 1, we looked at, can we actually do this? And then in phase 2 is, can it be feasible to just look at the automated numbers? So we looked at a few different things. We measured the agreement of inflammatory activity of clinical exam alone, whereas 2 uveitis specialists grading the patient, one of the 2 for each patient, and looking at saying, are you active or inactive based on just clinical exam? And then going back and looking with imaging, and that combination of clinical exam plus imaging was defined as the gold standard. And we then compared that to a masked reader who didn't see the images, just sees the numbers. So just what's the output, and we're measuring the level of agreement between those at different time points. And before we saw the images, either Dr. Srivastava or myself graded the patient on just exam alone, as I mentioned, and then we reviewed the imaging. And then separately and completely masked, a masked reader just reviewed the numbers, and we established cutoff on numbers of what we considered active or inactive. And for FA, it was a leakage index of more than 4%, an OCT cell density of the anterior chamber of more than 8 cells per millimeter cubed, and a central subfield thickness of more than 350 microns. Any one of those 3 was considered as being active. I'm going to skip over the demographics, but when you look at the overall exam only versus the gold standard of exam plus imaging, you see the sensitivity is not actually great. You miss a decent number of patients who are actually active on either imaging that get missed based on clinical exam alone. So the sensitivity is 56.3%, and so the kappa correlation is about 5.56. Versus if you look at the masked reader versus the gold standard, we see a sensitivity and specificity over 90% and a kappa score of 0.87. So that just the numbers alone were able to determine activity better than exam alone compared to the combination of exam plus imaging. And so our next steps are to assess the risk of vision loss by the imaging measures, but implement these measures in real-time daily clinical practice, and also eventually implement it in clinical trial as an endpoint. So what about remote diagnostics? So could you take images only and assess the anterior chamber, the sclera, and the cornea on OCT and determine the cause of a red eye? So we had 42 eyes who were imaged on anterior segment OCT in an optometry office that were then remotely read. This is a undergraduate student who did not have any training on what they were looking at, just looking at the images, and was able to, in 33 out of 42 eyes, give a diagnosis of what was causing the red eye, versus a uveitis specialist was able to do it in 39 of 42. One of the eyes was missed because there was keratitis that wasn't imaged, but all 13 eyes that had active uveitis were successfully diagnosed by both the student and the uveitis specialist using just the automated cell counts. So it's interesting because you can start to get some interesting data as remote diagnostics, but can you even take it further and determine whether somebody has infectious uveitis versus non-infectious uveitis? And the answer is maybe, because this is a receiver operating curve and an AI-based algorithm that's trying to predict the disease subtype just looking at a single anterior segment OCT image and using that anterior segment OCT image to predict whether it's infectious or non-infectious uveitis. And so there's some interesting data there. The ROC curve is about 0.8. And we're generating these continuous measures now of both anterior and posterior segment inflammation that can quickly be generated using our commonly available imaging modalities. And these advancements are going to help us improve monitoring and enhance development of therapeutics in uveitis. And maybe as we continue to advance on them and continue to develop them, we'll actually be able to do more than that, and we'll be able to do remote monitoring and remote assessment of inflammatory activity. Thank you. And here's our lab that's helped with all of this, and it's been a big group, and we throw an annual Ugly Sweater holiday party, and that's all of us this past year.
We should go, please.
Great talk. I loved it. Is your algorithm able to differentiate cells from pigment that's been released when you
So in general, the pigment tends to be smaller, and we're looking at a certain size threshold cutoff, and we can differentiate between the two.
And what happens if there's more proteinaceous stuff as opposed to cells, the flare?
Yeah, so flare is hard. Flare is hard to pick up on OCT because it just shows up as more of the background noise, and we haven't been able to really differentiate that well. The same thing with vitreous haze. An OCT-based vitreous haze assessment has been described, but it's really hard to do well.
How much of a learning curve is there for photographers or technicians to learn to image the anterior segment well so you get accurate measurements?
Yeah.
I mean, you're doing it at Cole all the time, and so I'm sure the
there is
photographers are really...
absolutely a learning curve because you're actually telling them to image the blank area, but what blank area is correct? Is it the air or the anterior chamber? So teaching them that skill, there is a learning curve involved in that. I actually think with the new swept source anterior segment OCT, it's much easier, and there's almost no learning curve with the new swept source anterior segment OCT.
I think it's machine-based also. I think
Oh, absolutely.
Easier on machines that were made to do anterior segment OCT and harder on machines that aren't made for that. Awesome. Nice job, Sumit. You want to introduce Usha?
Our next speaker is Usha Chakravarti, who's going to be talking about proxies for fibrosis in the outer retina. Does persistence of hyperreflective material after anti-VEGF therapy matter?
Thank you very much. Great pleasure to be here. So I have some relevant disclosures, which is a lot of interest in fibrosis right now because it remains an unmet need in wet AMD, and some disclosures non-relevant. Now, it's interesting because we have noticed over time that meta-analyses show increased heterogeneity in reporting of prevalent and incident fibrosis since the introduction of anti-VEGF. And funnily enough, also after the introduction of imaging with spectral domain OCT. And while one can understand why introduction of anti-VEGF with the severity of fibrosis changing and becoming quite variable, it might pose challenges to detection by the traditional on-fast methods of color and fluorescein angiography. Why should it be different when you have OCT? If you look at these images over here, these are eyes that have been treated with anti-VEGF, and there hasn't been suboptimal therapy because these were from a clinical trial. One eye has developed fibrosis, very obvious on color imaging, another hasn't. And there's a little bit of subtle fibrosis could be easily missed. So hyperreflective material on spectral domain OCT has been used as a proxy for fibrosis, and this seems to have resulted in even greater heterogeneity in reporting of fibrosis prevalence and incidence. Hyperreflective material is highly pleomorphic. It can be homogeneous, it can be heterogeneous reflectivity, it can merge imperceptibly into the surrounding tissues because it might be constituted by fibrin, whole blood, or it can exhibit distinct margins because it becomes encapsulated. And it can change with treatment, can reduce, it can condense into well-defined material, and can completely disappear. So here are some examples. These are all from my clinic. So I'm very pleased to say that our imaging photographers tend to produce very high quality images because, like Glenn says, these were people who were trained as photographers and did their various tests. So you can see in the top two panels, you can see disappearance of the hyperreflective material because from type 1 and type 3 membranes, whereas type 2 membranes and PCB, there's persistence of hyperreflective material. So you can understand that sometimes when there are data reported from studies where they might be reported at various time points, not necessarily at a fixed time point, like say 1 year or 2 years, but at various time points, and when there's been a bias in terms of the type of lesions that were included, that there are variations. So what we did was we wanted to see what the agreement was between the imaging modalities in detection of fibrosis. It's important to know when fibrosis develops, and also if you have new therapies that are coming in to prevent or ameliorate fibrosis, that you want to know how to measure it and how to report it. So we looked at a study repository containing multimodal image sets of patients who had been treated with wet AMD in a longitudinal study, and we took the month 18 image set because by this stage they should have either had resolution of all their hyperreflective material, because OCT was the imaging modality that we were going to test. And then we realized that there's never been a real agreement study between color and fluorescein imaging, even though both have been used extensively in clinical trials to report the presence of fibrosis. So we had color, autofluorescence, fluorescein angiography, infrared, and spectral domain OCT. But we really found that autofluorescence and IR were unhelpful because the agreement between our graders, because this was done by multiple graders to look at intra and intergrader agreement as well. So we concentrated on color, FA, and SDOCT. So here was the order of assessment: CFP, FA, and OCT. In that order, they were told not to go back and refer to the prior modalities. And you can see that color versus FA, the agreement was 0.56 kappa, and color versus OCT, the kappa was 0.40. Not great, moderate agreement at best. Then we looked at the localization of the hyperreflective material in relation to the RPE. And when we subdivided it by whether there was subretinal, sub-RPE, both subretinal, sub-RPE, or you will observe that the agreement increased quite dramatically when this hyperreflective material, which was, our definition was structured, linearly oriented, hyperreflective material that was persistent at 18 months, then the agreement improved quite dramatically, both with color and with FA. Then we attempted a validation of our findings. We did a regression model with a variable of best corrected visual acuity because we had function and we had the independent variables of the hyperreflective material location, whether it was subretinal or subpigment epithelial, and we also included the dimensions to understand what the impact might be. And you can see compared to the reference category of no hyperreflective material, the 130 eyes that we observed, that we analyzed, the presence of subpigment epithelial material resulted in a reduction of visual acuity of around 8 letters, and with subretinal nearly 20 letters. And of course, longer length and a greater height also had an impact. And just to finish off, in the 7-year IBAN trial, we had data from on grading of hyperreflective material. Of course, in the 7-year IBAN patient population, we had spectral domain OCT. We looked for disorganization of the outer retina, which we called ROLL, and we looked at whether the hyperreflective material was located subretinally, sub-RPE only, or both. And to cut a long story short, when you look at the cross-tabulations of HRM with ROLL, you can see that when it was subretinal or with or without sub-RPE, then there was an 8-fold increase in disorganized specialization of the photoreceptor layer, whereas the odds of having disorganization at the outer retina was increased only fourfold when it was sub-RP only. So here are my take-home messages. Spectral domain OCT detected well-defined, structured hyperreflective material, and we think it can be used as a proxy for fibrosis. The agreement with the current standard, which is color-detected fibrosis, and it had good sensitivity and high specificity when the HRM is subretinal. And it is important to define the location of the hyperreflective material in relation to the RPE and preserved photoreceptors, because when it is subretinal, there's an 8-fold increase of withdrawal and severe vision loss, whereas with sub-RPE only, the risk of withdrawal is much lower, and there is a lesser adverse impact on function. I'd like to acknowledge all the various people who worked on it, and thank you for your attention.
Usha, great talk. Questions from the panel or comments?
I was just going to make a comment. I think it makes some sense that the visual acuity would not be as bad if it's sub-RPE, because many of those are fibrovascular pigment epithelial detachments that have a vascular supply that can help nourish the outer retina, that even in the presence of fibrosis, that can help preserve it. Although you lose that when it's subretinal, and actually the RPE can break down and then you just get a fibrous scar, some of which have some vessels in it, but they don't nourish the outer retina like that.
I completely agree with you, Glenn. But I think what we also wanted to point out was that sub-RP fibrosis is also not as good as having no hyperreflective material at all. I think that's something that is also important.
Yeah.
Great. Thank you, Usha. That was a great talk. Final one for the session?
Yeah, we'll have Boz Williams come back and talk to us about OCTA and ocular oncology, and then we'll stay on time, or sort of on time, and we'll skip the panel and go to the break after that.
All right. So thanks again for having me here. Very much appreciate it. We will talk about OCTA and ocular oncology. Once again, my financial disclosures. Which are not relevant. So obviously, the Shields team really talked to us about the importance of VDI-OCT in these ocular tumors with an undulating pattern that we see for metastasis and lymphoma, and more of a dome-shaped appearance that we see for nevi, melanomas, and hemangiomas. There has been much more of a conversation about the application of OCTA technology in these tumors, but we also know that when you have pigment, especially some of these larger pigmented lesions, that can cause posterior shadowing, affect your transmission signal, and cause segmentation failures as well. With swept source technology, though, we do have the ability to assess deeper into the lesions, and so there's the question as to whether or not using this technology would be better. And even some technologies are now able to get significantly more depth, up to 6 millimeters in thickness. Where you can use this technology for anterior segment lesions. You can see kind of this beautiful image here where you can capture your iris cyst quite well. And so we'll highlight a couple of things about applications of OCTA in ocular oncology, and we'll start with whether or not you can use this for diagnosing or following choroidal melanomas. So in 1992, Bob Folberg's group really described 9 different intrinsic vascular patterns for melanomas, and they've been associated with long-term prognosis as well. And I'll go back here. OCT, these patterns have also been seen in ICG angiography, especially for lesions that have broken through Bruch's membrane. And so can you use OCTA to identify the intrinsic vascularity? We already talked about some of the limitations here. Here you can see, even with swept source technology, looking at the retina choriocapillaris and choroidal layers, you really can't see much in the way of intrinsic vascularity, and what can you do with that? So here, ICG, you can't really identify specific individual patterns, but you can see intrinsic vascularization, again, in a mushroom-shaped tumor that has broken through Bruch's membrane, and you can see in OCT angiography the mimicking or the similarity in the pattern. However, this is a lesion that's broken through Bruch's membrane. What about a lesion like this? This is only 1.9 millimeters thick, and it really looks like there's a flow void on OCT angiography, and is that actually real? So in clinical practice, this was diagnosed diagnosis of melanoma and the patient was treated, and so OCTA wasn't quite helpful in this kind of scenario. What about these lesions? So up at the top, you see a choroidal nevus with kind of a well-described pattern of a hypo area centrally with a hyper kind of ring. And down bottom, you see another nevus with kind of a mixed pigment pattern, and actually does look like there's intrinsic vascularization there. But in reality, you're probably just seeing the normal choroidal vessels because of the mixed pigment pattern. And so you have nevi that look like this with two different characteristics. You can't really tell much about whether or not a lesion is a nevus or a melanoma. What about management of choroidal nevi with subretinal fluid? So here you have two different pigmented lesions, both with overlying lipofuscin and some areas of subretinal fluid. So we'll take this lesion first. OCT angiography nicely shows the choroidal neovascular membrane here. The patient gets a couple of injections, responds nicely, and they end up doing very well. How about this lesion here? You're not really seeing anything on OCTA as far as the neovascular membrane, despite the fluorescein angiography and ICG potentially indicating that something is there. The patient was just watched and the fluid eventually went away, indicating that this was likely just a leaky nevus due to the lesion rubbing up against the RPE. And how about this situation? So you have a 76-year-old patient with a history of lung cancer. You have this kind of lightly pigmented lesion, but you also have blood there in the macula. You get angiography, and it kind of suggests that maybe there's a neovascular membrane there, but you can see it very nicely on OCT angiography. Now, while this doesn't differentiate a metastatic lesion from a different type of lesion, seeing a choroidal neovascular membrane indicates that you have a chronic lesion that's damaging the RPE and allowing the blood vessels to creep under the retina and then bleed. And so this is more indicative of a choroidal nevus where the patient could be treated and it was different or not related to the underlying lung cancer. What about diagnosis of other intraocular tumors? So this is another patient with lung adenocarcinoma with multiple lesions to the choroid, and you can see on kind of this enhanced field imaging that we'll talk about in a second, you have multiple areas of flow void. When you kind of see the 6 by 6 millimeter cut through the main lesion, you see flow void, and the same with the smaller two lesions down below. Well, what does that mean? Is that actually indicative of flow void? We know that with metastatic lesions, you have this lumpy, bumpy kind of appearance in those, so that can really affect your segmentation. ICG and OCTA show similar patterns here, but you can actually see that over time, as the lesion gets treated, that appearance of flow void actually kind of goes away and probably was just artifact all along. Can you diagnose lesions by OCT angiography alone? So we do know that some of these lesions have different patterns that have been described, and you can probably tell some subtle differences between the lesions, but honestly, it's really hard to differentiate a specific lesion based on OCT angiography. However, if you look at melanoma and hemangioma, you know that melanomas are supposed to have some posterior shadowing due to the pigmentation, even though they're supposed to have intrinsic vessels. Hemangioma, you're supposed to see much more flow there. And while you can tell the difference between these two lesions, it's obviously much easier to tell on ICG angiography, where you get the flow or the hyper early on with a late washout. And so diagnosis of other intraocular tumors really not ready for the prime time with OCT angiography. What about the study of treatment side effects? So Dr. Martin already talked about protocol AL. We do know that post-radiation, for melanomas in particular, a lot of our patients will get capillary dropout and they will get some levels of ischemia, which show nicely on OCT angiography. So if you get extended field imaging using this kind of adapter, which you put in between the OCT and the patient, you can really get a nice field for the OCT angiography, and you can look out at peripheral areas to assess ischemia. And what is interesting in this scenario is we normally think about fluorescein angiography showing us ischemia due to radiation retinopathy, but you can actually see as you look deeper on the OCT angiography that the choroid is significantly involved. So it's probably not radiation retinopathy. There's a component of radiation chorioretinopathy that we have to consider as well. Here's another example, fluorescein angiography of a patient where you look at the extended field imaging, and you can see some areas of peripheral ischemia perhaps, but realistically as you go deeper, this is where you can see the dropout. And so once again, this is likely choroidal involvement. Sometimes that's even more prominent than what we see in the retina. And here's another example where you see retinal involvement, and you can also see the choroidal involvement as well. So I think it is really important to kind of keep in mind how much the choroid can affect things. And here's another example on your OCT technology. Not only do you see capillary dropout in the macula and in the periphery, but you also see some vascular remodeling indicative of radiation damage. So we know that OCTA is able to image intrinsic microvascularization in some lesions despite thickness and pigmentation, but it can be really hard, and OCTA is not diagnostic, at least not yet. You can use it for detecting secondary CNVs and for monitoring treatment side effects, but it still has a long way to go in the ocular oncology world. Thank you.
Please, Usha.
It may not be diagnostic, but it could turn out to be prognostic, because if you have a much more vascular tumor, perhaps it might be more likely to metastasize. Is that something that you guys are looking at?
Yeah, so that's a really, really interesting question, and I think there are different vascular patterns that are associated with worse prognosis and a higher risk of metastasis, but the vascularity itself, it's hard to tell whether that leads to metastasis more so than the pattern. And so we can see when there's vessels there, but the pattern we can't really tell yet on OCTA. So
I've got one more quick question, if I may. So we've used OCTA in patients who get head and neck radiotherapy because they can have very subtle signs of radiation retinopathy. Is that something that is also part of your protocols?
Yes, absolutely. So anybody that gets head and neck radiation, especially if it's over 20 gray, they might be at risk, or not only over 20 gray, if they have other vascular signs, so hypertension, diabetes, or if they've been on cancer therapies, which can sometimes potentiate the radiation effects. We do that. We also get this in all of our follow-ups of patients with uveal melanoma or other conditions that have been treated with plaque or external beam radiation, so we can identify the progression of radiation retinopathy early when it's in the subclinical phase. Whether or not treatment at that time makes a difference, I don't know, but we're trying it to see what we can do for the patients.
Excellent. Yeah, another question, yeah.
Very hard to hear what the audience is asking.
Consider a role for OCT in retinoblastoma.
Roving man.
Yeah, so the question is there a role for OCT in retinoblastoma patients? 100%. Not only does OCT help for determining visual prognosis, looking at fluid, the photoreceptors, et cetera, but it's actually being used in people we know have genetic mutations to identify invisible tumors before they're clinically apparent. So we do screening OCTs on those patients with genetic mutations, and you can actually identify the tumors and you can treat them before you can clinically see them.
Awesome. What a great first session. We're going to go ahead and take our break. We're going to come back here at 8:40 and start the second half. Thanks for coming, and please enjoy some refreshments. All right, Alexandra Racheskaya, welcome back. Retinal imaging in adults with the history of prematurity. Tell us about this.
Thank you. So these are my disclosures. So why do I talk about patients with history of prematurity? I'm not a pediatric retina specialist. And it's because I think this is a problem that affects anybody who does surgical retina. More and more babies that are born premature survive to adulthood. And a lot of them have no signs of prematurity. So unless you ask, you wouldn't even know that they are premature. This is just a study showing that if you look at over 7,000 premature infants, only 43% developed ROP, and out of those, only 7% underwent treatment. So sometimes you might have a patient that actually had ROP but didn't require treatment, or in this new era of anti-VEGF, they might have no signs of prior treatment either. So Why does it matter? Well, it's been shown multiple times that these patients are at higher risk of developing retinal pathology, retinal tears and retinal detachment. That wouldn't be the problem because we're good at fixing retinal detachments, but their reattachment rate with one surgery is significantly lower than what's reported in the literature in general for RD repair. In this study, it was 80%. In this other study, it was 77%. And in this study of over 350 eyes, it was 63%. So there's something different, obviously, about these patients. And we have this low rate of one surgery and final reattachment, worse visual outcomes. And so there's a discussion of how often should we follow these patients, and also do we need to modify our surgical technique if you know that the patient is premature. So this is what brought it to my attention. This is not the proudest moment I had. This is a patient with significant prematurity, which I actually didn't ask the question before, and discovered this intra-op, and you can see how we couldn't lift the hyaloid at all. This is where it got stuck, and as you can, if you try to lift it up, you would create tears. So as my fellows know, I meticulously ask now everybody if they were born premature, and I think it's in some secret book, so all the fellows know to ask that as well. So, and sometimes you have some stigmata of prematurity. You know, they might have straightening of the vessels, or a lot of peripheral pathology, like in this patient. And of course, you can do an FA and find peripheral non-perfusion, but how many of us do FAs on our retinal detachment patients? I suspect nobody. So there's literature in kids looking at foveolar vascular zone. And it shows that in children with a history of retinopathy of prematurity, so not just born premature, but actually with a diagnosis of ROP, the FAZ appears to be smaller, it's reduced. And in this population, these findings have been found to correlate with visual acuity. So we wanted to look at adults, and the adults that we chose were adults that have never been treated for ROP, and we looked at, also compared that to healthy controls, and we looked at OCTA to address not only the size of FAZ, but also its circularity, how close to the circle it was, and vascular density of the superficial and deep capillary plexuses. And then we correlated that with OCT findings as well as visual acuity. So these are patients who are seen for standard care in a retina clinic. They have a self-reported history of prematurity, and we had 17 eyes that we studied and had 11 age-matched controls. This is demographics. You see most patients on the younger side, and they have overall pretty good visual acuity, and this is what their presenting diagnoses were. So what did we find? So we find, just as we saw in kids, is that foveolar vascular zone appears smaller. This is 6 by 6 and 3 by 3, and you can see that FAZ is smaller. And this is just to compare it to a healthy control, and you can see profound difference in these patients. So when we looked at and measured it, we saw that in terms of the area, adults who were born premature had smaller FAZ. It was also less circular. Interestingly, when we looked at the superficial and deep capillary plexi in these patients, we also saw that although FAZ had denser vessels, they had less vessel density if you looked on 6 by 6 scans. We also looked at the OCT and measured this foveal dip, because it's been reported that it's smaller in the patients with the history of prematurity. We also, though, measured not only that, but average cube thickness. And what we found that, as been reported previously, the foveal pit depth was smaller in adults that were born premature, but so was the average cube thickness. So if you just looked at the central subfield thickness, you don't necessarily see the difference between the two cohorts. In our cohort now, once again, the difference is this is not adults who were treated, they just were born premature. Overall, we had pretty good visual acuity, and visual acuity in our sample didn't correlate to any OCTA or OCT findings. So this we all are going to take care of these patients, and these patients have been reported to have more retinal pathology that might be more challenging. And OCTA is a very easy and non-invasive method to potentially identify these patients. And I think this is something that's become of interest to me as we see these patients, and characterizing peripheral pathology as well. So this is an example of a patient that was premature, and although there's all these pigmentary changes, they were never treated. And you can see these significant areas of schisis and abnormal vitreoretinal interaction. This is another patient, and that patient was actually referred to me for an ERM evaluation, and I selected not to proceed with surgery. As you can see, these peripheral changes are profound, and very thickened hyaloid face. This is a patient that came in and actually had subretinal fluid, and you can see this area of traction. So we imaged all the way around to make sure that there was not a rhegmatogenous component, and continued following these patients 3 years later. And there's also work looking at the peripheral non-perfusion in these patients, and if it correlates to some of these findings. So I would like to thank everybody who is involved in this project, in particular Jacob Cox, who was our fellow and has submitted this for publication, and I welcome any questions. Sorry?
Alexander, what was your definition of prematurity in this sample? It seems
Yes.
to vary from study to study.
So you exactly hit the nail on the head. That's one of the biggest limitations of this study, because unfortunately, with electronic medical records, now we'll have some data, but the patients come in and some of them know exactly how premature they were, but a lot of patients know they were premature, but don't know exactly. And there's such a range, right? So but it was interesting that in everybody who identified as premature, we saw that finding. So, but significantly more work needs to be done. And as we have longer follow-up and hopefully ability to look back at the early data for these adults, we'll have more information.
So in our Northern Ireland cohort for longitudinal aging study, which was set up, about 6 years ago, we have data from over 5,000 people who were imaged, just randomly from the population. We found foveal hypoplasia in something like about 6%.
Right.
And obviously, one or two of them had albinism, but the rest, we have no explanation. So something maybe... We'll go back and look at those and see whether we certainly have the date of birth, and we might have some records on.
That would be
there.
interesting, yeah. And actually, to give a shout out to Duke again, it seems like there's a lot of work that goes together.
We can give a shout out to Glenn.
I had nothing to do with that.
No, but they've been looking actually at imaging babies that are born premature, and looking at the changes that might be happening with OCTA, trying to figure out how that process progresses. Depends on when the baby is born.
We also have OCTA in some of them as well.
Yeah, fantastic.
Awesome job. Thank you. Next is Glenn. Speaking of Duke, Glenn's coming back to talk to us of a near and dear topic of mine, imaging characteristics of intraocular inflammation associated with retinal therapies.
Thanks very much, Sunil. And again, my disclosures. So you can think of intraocular inflammation associated with drug therapy as a couple of different types. It could be a systemic drug that causes inflammation, for example, rifabutin that causes intraocular inflammation, or anti-resorptive therapy. That's not what I'm going to be talking about today. I'm going to be talking about the inflammation that occurs specifically because of the drugs you're using to treat somebody and trying to make them better, and then you get inflammation from those drugs. So it seems self-evident why it's an important topic, but this is it's a hot topic now, and it's one that people are very sensitized to, the patients, the physicians, and the pharmaceutical companies. So intraocular inflammation is increasingly recognized after retinal therapy, whether it's biologics, whether it's gene therapy, whether it's small molecules, and the inflammation that you see depends on the particular drug. It's very heterogeneous. It may be stereotypical for a certain drug, but it varies across drugs. But it can be vision threatening, can affect patient safety, and it affects the physician acceptance and the patient acceptance of a new drug therapy. And we've seen this several times recently. The reporting, though, of the inflammation has been inconsistent. And as I mentioned, the presentation really varies by the type of drug. And you see, for example, the inflammation that occurs with brolucizumab. And I know Sunil is very involved with looking at these cases of brolucizumab. It causes occlusive vasculitis. Hypotony and vision loss put a halt to the Adverum phase 3 neovascular AMD studies because of inflammation associated with hypotony, and they had to scale back the whole operation to a phase 2 study, and now they're ramping back up for phase 3, but it almost put the company out of business. And you're very familiar, I'm sure, with the cases of pegcetacoplan or Syfovre with, again, a hemorrhagic occlusive vasculitis, which looked different than the brolucizumab cases, which looks different than the cases with Adverum, which looks different than faricimab. So what I'd like to do is to propose a standard way of evaluating these patients that includes the clinical assessments, your imaging protocols, and the features that we assess on the imaging. And the goal is to try and develop consensus so that we have an accurate description when we're describing these patients, because the descriptions have been pretty muddy. We have the Sun anatomic classification, and I was involved in this, but this classification, which goes anterior, intermediate, posterior panuveitis, is helpful, but it's really not granular enough for the drug-induced inflammation, which causes a variety of features, and as I mentioned, they vary by drug. And another important aspect of this is the retinal vasculitis that we see. And people don't have a consistent definition of vasculitis, and the one that I've been using to call something vasculitis means there has to be inflammation associated with the retinal vascular changes. Typically on an ophthalmoscopic exam or color fundus photography, this means sheathing of the vessels. There may be occlusion or leakage on the fluorescein, but just because you have occlusion, you can't say it's occlusive vasculitis. And some of the cases that have been reported with drug-induced inflammation have actually just been occlusion, for example, an artery occlusion in a diabetic who is predisposed to it to begin with. These are examples of true retinal vasculitis where you get the leakage from the blood vessels, you see sheathing around the vessels on the color fundus photograph. Occlusive vasculitis, where you see the perfusion deficits in the arterioles, and in this case, has caused associated retinal whitening. So the assessment is based, that I've put together, and this is what we're using now at the Reading Center as a standard assessment, is based on all the cases that we've had to date, and I'm sure it's going to evolve, and we're going to get more cases in the future, but as new drugs come in, and there's going to be different patterns. But clinically, when you see the patients, we use visual acuity, we use intraocular pressure. I showed you the example of the hypotony. Some of these inflammation cases have elevated intraocular pressure. People are finally now getting attuned to doing slit lamp exams before they give injections to their patients. And in the past, people would just give injections, and we saw this at the Reading Center as we started evaluating these patients, where you'd see inflammation on the OCT preceding the episode of inflammation that had not been recognized by people who were just giving injections. And so I think the importance of looking at the anterior chamber and looking at the anterior vitreous to look for cells as a precursor of potential inflammation is really important. What about ophthalmoscopy? We have all this great imaging. Do you need to even do ophthalmoscopy? I think it actually is quite helpful. It's helpful for assessing vitreous haze, and on our photographs, we can't necessarily tell whether it was a bad quality photograph or it's because of actual pathology. For ultra-wide field imaging, you're all familiar with the lash artifacts that you get superiorly and inferiorly, and sometimes those can hide underlying pathology. You can ask the photographer to shift the image superior or inferior and get away from the lash artifacts, but they don't always do that. So the imaging protocols that we use for intraocular inflammation are multimodal. They include fundus photography, fluorescein OCT, OCTA, and ion and green angiography. The protocol that I have recommended, and we're actually doing this as a standard at the Reading Center now, even for macular degeneration, we're doing wide field imaging so that people at the clinical sites don't have to learn two different imaging methods, one for the macular degeneration, for instance, and one for IOI. So the Optos is a preferred method, getting ultra-wide field imaging, 220 degrees, or a Zeiss Claris, or 4-wide, which is 45 to 60 degrees, and that's easy for the photographers. And as I mentioned, we're trying to establish protocols that are easy, but that'll still give useful information. For fluorescein angiography, again, Optos is preferred for two reasons. One, because it's a lot easier for the photographers to do, or the technicians, who's usually the ones doing it. And also, we obviously can see in the periphery. We need to see in the periphery to look for leakage when we're looking for intraocular inflammation. The 4 wide is also a second best option. I prefer Spectralis. I know at Cole you use a lot of Cirrus. I just feel the image quality is better, but you can use Cirrus as well, but it's helpful to have high density scans, and we get a macular volume scan at 97 line and 7 line scan. For OCTA, typically a 6 millimeter by 6 millimeter and a 3 millimeter by 3 millimeter. You can go wider field. You have even more problems with the artifact as you start getting wider and wider. And I would just show the difference in the imaging that you see. Here's a 3 by 3 image. You get very high resolution images, but they don't go out very far. And you can do montaging to help with that. For ICGA, we like a combination of still images and video, so you can actually see the transit and look at the leakage in the choriocapillaris. Well, so now you've got your images, what are we actually looking for? And this was a publication that one of my colleagues, Dilraj Graybal, led on the brolucizumab cases that had been post-marketing. And we put together predefined grading variables, which are the ones that we're looking at, and they're based on the different imaging modalities, and the list is different depending on the specific imaging modality. So let me show you some examples of these. So with fundus photography, I've shown you a list of variables, the things that we're looking for, and here's an example of one that has a cotton wool spot and also Kyrilli's plaques. So what are Kyrilli's plaques? They're these sheathing, or they're a yellowish-white appearance along the arterioles that often have a skip appearance. They were originally evaluated in toxoplasmosis, but we see them in certain types of drug-induced inflammation. For example, that was one of the keynote things that we saw in the brolucizumab cases. And here's an example. This also was, this actually was a brolucizumab case. This is one where we saw a variety of these features, including you see the color coding, the vascular sheathing at the green arrow, retinal whitening, which was a focal infarct. Also saw media opacity, and this also had Kyrilli's plaques as well. For fluorescein angiography, we're particularly interested in vascular leakage, and so here you see an example of focal leakage. The leakage can be diffuse or focal. And this is an example of boxcarring from retinal arterial occlusion, and you see the occluded vessels. Here you see more diffuse leakage on fluorescein angiography, and also see a hot optic nerve, which is also very helpful for characterizing the inflammation. OCT is also useful, and we look particularly for focal hyperreflective foci in the vitreous. Sometimes they go along the vitreous cortex, as you see here. You can also see stalagmites, emanating from the inner retinal surface, and that's also a sign of inflammation. OCTA is helpful for looking at the vascular occlusion, and also for looking at deeper structures. So in this case, you're seeing choroidal hypoperfusion. So I think there really is an unmet need to standardize the IOI reporting, and this is just one example of a proposed reporting feature list. And the whole goal is to try and accurately describe this. So when we're talking about IOI from a particular drug or another, we're actually talking about the same thing. And the next step is to get consensus. So I would encourage people like Sunil to help me with this project so that we can actually come to consensus on the imaging standards. Thank you.
Questions to panel? I have a few. I'm curious. So, do you think, Len, it's time? I mean, you and I have been involved in a couple of these. You know, one of the challenges I think reading centers have, clinicians have, is sometimes they don't have all the information at once. And specifically from a reading center perspective, maybe somebody is looking at OCTs, maybe somebody is looking at fluoresceins, but is there a role for like a safety monitor at some level from an imaging standpoint who looks at everything together? When I've reviewed these cases, at the early stage, sometimes it was a subtle sign that you picked up on one and then you had to correlate with another sign on another imaging test. So is it time for some of these, trials to have something at that level where there is, I don't want to say a monitor, but at some level, somebody who's assessing the safety from multimodal imaging?
Yeah, we're actually, as we speak, we're doing that. So fortunately, we have people at the reading center who are uveitis and retina specialists. One in particular, as an example, is Sumro Onal, who's a professor of ophthalmology, but a uveitis trained specialist that is a senior reader at the reading center. And she looks at the images in a multimodal way. And for several of the sponsors, actually, so there's two ways that the cases can come to us, and my hope is that by doing these standardized protocols, by having a standardized way of looking at it, that people will actually recognize it in the clinics, and so these cases won't get missed. But we see it in two ways. The most common thing is we start to see these vitreous hyperreflective foci or the interretinal hyperreflective foci at the reading center. And then we send a risk management report to the site or to the sponsor to get the site involved to actually get the multimodal imaging so that we can then evaluate it. The other way they come to us is that the site sees something's going on, and then they'll do the standard imaging, and that's what we're trying to get them, because as Sunil was alluding to, we were on the safety review committee for brolucizumab, for instance. People were getting 3-field imaging that didn't go out, so you couldn't even see the inflammation. So we're trying to train the sites, but then when the site sees something, then they send the multimodal imaging, and we assess it in a multimodal way. So unlike the way that we grade for some of the other things where we have OCT specialists or fundus autofluorescence specialists, for IOI particularly, we have people doing multimodal evaluations.
That's great.
Glenn, has there been any thought of using AI to do this automated real time? So as the images come in and to train on, these are cases of inflammation, these are not, and can you pick it up as it comes into the reading center?
Yeah, that's a really good idea. It would be great to do it automatically. It would be even better if the sites could do it automatically, but as they're seeing the patient just press a button, would say whether it's inflammation. We haven't accumulated enough cases, fortunately, to be able to generate a large training set. The other issue with the cases these cases are different than the doing AI on a patient with geographic atrophy or neovascular AMD, where typically the media is pretty good. The patients who get the IOI often have vitreous haze. It's hard to see the back of the eye. The image quality is not so great to begin with, and then you add all the media opacity on it, and you can't even see the features very well. And then you don't want to be triggering a lot of false alarms because somebody has hazy media, which in fact was just because the images were out of focus. So it's a challenge, but it would be great to have that.
I think clinicians are also getting better at the site level to recognize some of these things.
Yeah, and that's one of the goals of having a standardized method and encouraging to do imaging in a way that they could actually see the inflammation.
Thank you, Len.
Thank you. Our next speaker is going to be Sunil Srivastava, who's going to give us the ellipsoid zone integrity as an endpoint for both dry AMD and in posterior uveitis.
Great. I'm going to do my best Justice Ehler's imitation, and here are his financial disclosures. We can all criticize or mock them or compare them to my financial disclosures, and they're about the same. I do want to say that I do serve on multiple data safety monitoring committees, none are relevant to this, and we do have patents on multiple imaging analysis algorithms, which we're going to talk. So let's talk about a little bit. We alluded to this a little bit before about the ellipsoid zone, and quantitative ellipsoid integrity is emerging as a biomarker for multiple diseases. So EZ integrity has been correlated with visual acuity and recovery in macular holes, epiretinal membranes, RDs. The list goes on. And most early studies have been qualitative when you assess these patients, or quantitative from one single B scan through usually a foveal cut. It would be great if we could actually look at the whole macula, and this kind of work hasn't been done until really more recently. So is this something that we can use in multiple diseases? And we're going to specifically focus on intermediate AMD or AMD in general, and then I'm going to talk about uveitis right afterwards. There are lots of challenges when you look at EZ integrity and look at it specifically in intermediate AMD. And this can be related to the complexity of drusen anatomy and the variability of the drusen, the impact of the OCT OCT itself, the directionality changes to the retina and the visualization of EZ band based on the anatomy of the drusen. And then what is the etiology of the absence of the ellipsoid zone? Is this an optical artifact? Is this mechanical compression? Is this pathologic? Or are there other causes why the EZ disappears in some of these cases? So we really try to answer this. We have to understand that not all drusen are created equal. We already know this. We actually know that there are multiple OCT features that have been linked to progression, whether it's hyperreflective foci, subretinal drusen deposits, whether it's hyperreflective drusen cores, iRORA, or persistent hypertransmission. Each of these things have shown us that they can lead to progression to a geographic atrophy. There are needs for clinical trial endpoints in this space, and we've alluded to this a little bit during this talk. Well, if we think about them, we want them to be functionally relevant. We want them to be minimally or disruptive to a trial site. We want them to be scalable, both at the site and a reading center level, and interpretable, be able to actually validate this for accuracy, and linked to key disease pathology of interest. So is what we're measuring actually related to the disease that we're talking about? So let's first talk about feasibility and reproducibility. So this is something we've been working on in both my lab and Justice Lab for the past 12 years. And we've developed a machine learning enhanced multi-layer segmentation tool. And this allows us to extract features to perform easy analysis. And so this is a multimodal, multi-architectural integrated system. There's lots of interactive checkpoints for accuracy and feature feedback. It works on multiple OCT devices. This allows for a certified reader objective assessment and segmentation accuracy. And we have a high-intensity training program for our readers to elevate this consistency and reliability. And actually, readers have to meet a certain criteria before they're elevated to the reading center itself. So when we are talking about EZ integrity, you're going to hear us talk about a couple of different terms. One is total EZ attenuation. So this is looking at the distance from the ellipsoid zone to the RPE and setting that threshold, setting that distance at 0. And then partial EZ attenuation is any EZ RPE thickness that's less than or equal to 20 microns on our distance. So we are looking sometimes at the central subfield, which is the 1 millimeter, or the central macular, which is a 2 millimeter foveal-centered diameter. So can EZ integrity be measured and reproducing in consistency? So this is some work that was done by one of our students, and looking at specifically at our dry AMD and dry AMD, looking at interclass correlation assessment to ground truth, both with our manual readers, our automated, pure automated, and then a semi-automated platform with certified readers. And you can see the correlation to ground truth is pretty high, with ICCs in the 0.99 range for multiple of these things, and in the 0.95 in others. So again, showing how well this technology can work with certified readers to manual reading. The EZ integrity measures that we're looking at, thankfully over time, have become something that pharma's looked at and regulatory sites have looked at, and now total EZ attenuation loss has become an FDA approvable endpoint for dry macular degeneration. So what is the therapeutic signal in advanced AMD? So there are multiple trials that have actually established that EZ attenuation probably is related to some form of this disease. So this is elamaprotide study looking at Reclaim. This is a targeted mitochondrial therapeutic that reduces EZ loss. This is, we established this as a phase 2 pre-specified endpoint, looking at total EZ attenuation with a retinal thickness of, that thickness of 0 or partial. And you can see the two curves here in the placebo versus the elamaprotide group, the reduction in loss over time in those who were treated. This allowed us to actually set this up as the signal for the phase 3 stealth program, and it's being used as a primary endpoint. But this has also been shown in other trials as well, whether it's in the 2 complement drugs that are out and available currently. So is EZ loss linked in any way to GA growth? So this is a lot of work that's been done, not just by our group, but other groups as well. This is the Vienna group looking at disease activity predicted by an EZ metric. This is the PR-RPE ratio, just another way of looking at the ellipsoid zone, and separating these into quartiles of thickness. And you can see the ones that are in the quartile 1 had greater loss and greater GA growth than the ones in the lower quartile. So EZ thickness might be predictive of those who are at risk to develop geographic atrophy. And this has been shown in other studies as well, looking in GATHER 1 and GATHER 2, looking at the ones who grow fast versus those who grow very slowly. And if you separate it out by easy attenuation, you can see that the mean attenuation is actually reduced and smaller in the ones who have slow growth versus those who are fast growers. And this is all comers. This is not just those who receive drug or those who don't receive drug. This is looking at all the patients who actually have loss. So is there a functional signal for easy integrity in AMD? So what's the association with visual acuity? Because ultimately that's what we were interested in. What's the visual acuity benefit, or what's the visual acuity association? And we've shown in multiple studies that there's an excellent association between less loss and better vision, and in both total and partial attenuation in the central macula. And this has also been shown in both GATHER 1 and GATHER 2. So if you looked at those patients who had both either partial easy loss or total easy loss and looked at the difference in vision change from baseline, you can actually see the ones that actually have, without vision loss, actually had lower easy loss over time than those who actually lost vision. So this vision loss is associated with greater progressive easy loss. And this is the further data just showing that. So what's the ability to then use this as developing as a biomarker for progression? Can we use this as a predictor for those patients who are going to develop GA? So as we said, not all drusen are created equal, so you can look at some of the maps here, the specific drusen map, the easy integrity map, and look at another patient who has a similar appearance from a phenotype OCT B scan, but you see their easy integrity loss actually looks worse. So over time, this patient actually loses more vision than they did the previous patient. And we have done work that actually looking at our 2-year progressors in our own internal system and found that the highest predictor or the best predictor of future progression to GA was easy integrity. So in conclusion, easy integrity appears to be a promising biomarker feature in dry AMD that can be utilized for risk prognostication and stratification. The change in slope of total easy attenuation is now an FDA approval endpoint for dry AMD and is currently being leveraged as a primary endpoint in an ongoing phase 3 program. Additional research is needed to better define the structure-function relationship and the optimal functional testing to link to easy integrity. And future work is going to also include assessment of various easy photoreceptor measurement approaches to better define critical windows of intervention and potential implications of various therapeutics mechanism of action. It's a big group that does this. Obviously, Justice has been working on this a long time, and this is the whole crew at the Advanced Imaging Lab at Cleveland Clinic. And I'm happy to take any questions before we talk about uveitis. Thank you.
There's been some pretty heated discussions with Phil Rosenfeld regarding looking at ellipsoid zone over drusen, saying that you can't measure change because over the drusen, if there's no ellipsoid zone, and after the druse goes away, it comes back because of the optical effects. And I was wondering what your thoughts were about how you look at the change in ellipsoid zone when it looks like it's coming back when it was there all along.
It's a great question. Actually, I think the next talk is going to help us with that, because there are very few diseases where the ellipsoid zone actually returns, right? So is there a appearance of an ellipsoid zone that's actually healthy, even when it looks unhealthy? And I think figuring out what that is challenging because we don't have that many diseases that do this. There's one disease that is near and dear than all of our hearts, is that uveitis is one of the few diseases where we see ellipsoid zone go away, if you will, and then return. My favorite disease, syphilis, is actually a great example of this. So there are probably features that are within this ellipsoid zone that that do return. So I think ellipsoid zone can disappear in a functional state and reappear based on what's happening in the outer retina. So I don't necessarily think that invalidates it. I just think it tells us that the disease state is changing.
Yeah, so far with intermediate AMD, it's been tough to differentiate pathologic loss from potentially just optical loss.
And I think that at one point, and again, I'll show this in a few minutes, but I think that's the importance of looking at this beyond just AMD. We have to look at it from all retinal diseases, because I think every retinal disease is, I think, in some level, helping inform what happens. When it's a purely inflammatory disease or an infectious disease, I think we all agree that inflammation probably plays a role in AMD. So understanding it in other disease states, I think, would actually help us figure that out. Was there a comment, question?
Apart from thickness, do you think that the reflectivity of EZ can be also a biomarker?
Yes, that's a great question. It's another thing we're going to talk about. I do think other changes in the ellipsoid zone, whether it's the intensity, the reflectivity, there are other metrics within the EZ that we think is important in predicting whether an EZ in the outer retina is healthy. Yes?
Some patients might seem to have disrupted ellipsoid zone, but yet surprisingly they might retain very good visual acuity. And this can be attributed that some of these cone photoreceptors are just non-wave guiding. So they appear to be quite disrupted, but yet the function might be still there. So how would you correlate this, say, for example, in cases of AMD?
Yeah, I'm going to say that we'll talk. Let's talk about it in uveitis, because I think it's actually a really good way to understand it. I think, again, for some of these patients who have ellipsoid zone loss, is it an optical, I won't say an optical illusion, or an optical change that occurs in a disease state that over time will see it completely lead to loss and either an RPE loss, or will actually reappear based on what's happening in other aspects of the outer retina. So I think it's just a signal. I don't think it's an absolute measure of health.
So why don't we move on to the uveitis talk, and then we can talk more ellipsoid zone after that.
This is exciting. The uveitis actually might be relevant. Let's do it. All right. OCT imaging metrics in outer retinal inflammatory diseases. Financial disclosures are probably getting worse as the time goes on. So OCT can be used to make a diagnosis. The residents and fellows always sit on that side of the room, and they're so smart that they can actually look at this picture and tell me what 4 diseases are occurring in this patient, in these patients. And the ability to use OCT in inflammatory disease is great, gives us a differential. But I think the ability to measure change on these patients is challenging. OCT thickness measurements aren't useful for half of the patients that you see here. Thickness measurements wouldn't necessarily tell you that there's an abnormality that's happening. So we need something more than this. And this has been work that we've been doing for a while to specifically look at this in inflammatory disease. So I'm going to focus on 3 that we've done some work on and actually show you changes over time and the implication of the ellipsoid zone and the changes that occur in inflammatory disease. So the first one's syphilis. So we wanted to quantify the recovery of the ellipsoid zone after completion of a 2-week penicillin treatment and to characterize actually other changes, specifically in the outer nuclear layer. So this is a retrospective review of 28 patients, 28 eyes of 16 patients. Each of them get a 14-day course of penicillin. Each has an OCT pre and post. And we use our automated algorithm with manual correction to actually look at the EZ thickness maps. 12 of these patients had bilateral disease, 45 years old, 14 were male, 8 were HIV positive, and I have a follow-up of me in about 30 days. So if you look at these patients, actually, initially, if you look at the patient on the left, there's significant loss of the ellipsoid zone, reduction and almost a complete disappearance of the ellipsoid zone in these patients. And as time goes on, the ellipsoid zone actually starts to come back. And so we look at a total attenuation map of this patient. So the patient gets treated at day 2 through day 15. You can see the improvement in the map where the pink represents 0 thickness. That thickness slowly improves over time, showing to us that the ellipsoid zone itself probably was not completely destroyed, or the photoreceptors weren't completely damaged. But there were some changes in some in the outer retina that occurred. But even at day 39, even though the patient has really good vision, the ellipsoid zone still has some attenuation, and that continues to improve over time in some of these patients. In those who have faster recovery, you can see it occurring very, very quickly in some of the patients where you get complete resolution by day 48. But even at day 48 in this patient who has a very good visual acuity, there's still patches of ellipsoid zone thinning and ellipsoid zone loss representing previous damage, and it doesn't necessarily correlate to the visual acuity completely. So when we look at these patients over time, we can see that the improvement in EZ volume and the EZ central subfield volume improves over time, and the amount of reduction in the 0 micron EZ map is pretty significant from pre to post treatment. That volume also reduces over time in these patients, as well as total volume and the central subfield volume. When we looked at these patients, we were curious to see if some of the patients who had disease in the brain, if this correlated to the changes we would see in the eye, and there was no real change or difference between the two groups. There was a pretty equal representation amongst this. So in this disease, volume recovery begins immediately after treatment initiation, and EZ recover continues after treatment completion. We still have loss in significant number of these eyes, even at day 33, and there's thinning in the retina that continues to show even at that period of time. HIV status and LP result doesn't affect recovery rate, but it is an early biomarker of response that we start to see even at day 3 to 4 in treatment of syphilitic retinitis. So we've looked at this also in other diseases, specifically AMPI, one of our favorite diseases, because right now no one knows exactly what to do for these patients. Half the uveitis providers will probably start these patients on prednisone. There's another group who would say these patients don't really need any steroids, they'll get better by themselves. So we published a paper a couple of years ago where we were using one of our early generations of our EZ metrics and doing this mainly manually. So I convinced a fellow and a resident to manually go through each of these ellipsoid zones and to actually mark them and quantitate them over time. And you can see our automated EZ thickness map version in 2020 versus a manual map that was done. And over time, what we found was these patients slowly would improve their ellipsoid zone in patients who were treated with steroids with or without intravitreal steroids. But what was very interesting is when we separated these patients into those who had pigmentation at presentation versus those who were non-pigmented at presentation, indicating probably chronic disease versus more acute disease. The pigmented patients improved slowly if they did improve, and the non-pigmented patients improved much more rapidly. Again, showing us that those patients who had more chronic outer retinal inflammatory disease had slower recovery and sometimes incomplete recovery of their outer retina. The last disease I want to chat about is birdshot. So the birdshot is a chronic inflammatory disease affecting the retina and the choroid. The disease, even when it appears clinically inactive, can progress with photoreceptor loss and ERG changes. So we sought to assess the degree of EZ loss with 3 forms of treatment: the surgical fluocinolone acetonide implant, systemic therapy, and those who just declined to have therapy. So these were 30 patients, 58 eyes, 25 eyes in the surgical implant group, 21 in the systemic group, and 12 in the no treatment group. What I want to point out in the beginning is to look at in our practice at least, the patients who get Retisert, so the surgical fluocinolone acetonide implant, tend to be the more severe patients. They tend to be the patients who've already failed multiple other therapies. And that shows true here when you look at the average 20 micron EZ map loss. The surgical fluocinolone implant group has the most of all 3 groups except the no therapy group. And in compared to the systemic therapy group, it's a significantly amount more, both in the 0 micron and the 20 micron group. When we look at these patients over time and generate maps, and we looked at this over multiple years with multiple implants in the surgical implant group, those who had, I'm going to show you 3 examples and then show you the overall, but you can develop these maps and see the stability of patients over time on these EZ maps. In some cases here with the surgical implant, this is another case of improving EZ metrics over time with the surgical implant, with the EZ loss actually reducing within the first year and then staying stable over the next couple of years. You'll see on the bottom there it says year 6 and then goes to year 2, year 3, year 4. At year 6, we put in a new implant, and at year 2, that's 2 years after the second implant. This is a patient who declined therapy over time for some reason. I think Sumit can convince them. And this patient slowly gets worse over time. And you can see the ellipsoid zone loss that occurs in this patient, even though their visual acuity is pretty good. Their ERG is slowly changing. We try to tell this patient to get therapy. They continue to decline therapy. And you can see the slow ellipsoid zone loss that occurs in these patients, even though clinically, when you look in their eye, there isn't that much activity. So this is the easy RPE map, the 20 micron map over time, and that's on the top is the surgical fluocinolone implant group, and the bottom is the systemic therapy group. You can see the baseline, we're all starting a little bit differently, but you can see the improvement over time in the surgical fluocinolone acetonide implant group, indicating that some of these patients can actually recover. And then you'll see this worsening that occurs at year 5, when the implant runs out and we start to change the implant out, and that takes time to again recover out to year 9. So why is it important to understand EZ and uveitis? We just had the discussion. It's one of the few diseases where the EZ can actually recover. So if we can identify the qualitative differences of the ellipsoid zone, whether it's reflectivity, thickness, or other changes, maybe we can actually identify sick EZ, the EZ that's unlikely to recover. So in summary, EZ recovery can be measured and quantified in a number of inflammatory diseases. I think these advancements will serve to improve monitoring and enhance development of therapeutics in uveitis. I think the imaging biomarkers still require additional work, but will enable more advanced assessment of inflammatory eye disease and other retinal diseases. Thank you for the time. Go ahead, Isha. Yes.
So I noticed that in syphilitic uveitis, and we all know that this happens, that there's a diffuse thickening of the outer nuclear layer.
Yeah.
So could that have interfered, at least in some of these cases,
Sure.
with detection of the EZ? It's there, but you can't really see it, and that as the edema disappears, it kind of recondenses and reconstitutes itself.
Yeah, I think it's an excellent point, and I think that is one of the things I think we always have to worry about is what is happening in the inner layers of the retina. Could that affect the outer retina? I will say, though, if you look at fundus autofluorescence of these same patients, they have distinctive hyperautofluorescent changes that map out to those areas of EZ loss. So it makes me think that I think I would support that this is probably more likely true EZ loss than the outer nuclear layer necessarily masking the EZ loss. You're giving me a skeptical look, so I let one head.
No. I'm not giving you a skeptical look. I'm considering exactly what you said, and I'm just wondering whether some of these mitochondria there could be, when you have this kind of inflammation, become popcorned and become very expanded. So as a consequence, you may not see the condensed areas. So yes, they are diseased.
Yeah. But so when we get out to even like day 33, where the ONL layer thins, the patient's been treated, the EZ loss is still present, though. So it's the ellipsoid zone loss is still present. It's not as much as when they first came in. But if you look at some of the patients I initially showed, the outer nuclear layer isn't that thick. I mean, there is some thickening, but not to the extent that I think it would necessarily extinguish your ability to see the ellipsoid zone.
If you can catch a few patients undergo radiation therapy, head and neck radiation therapy from these guys, and look at them, because radiation has profound impact on the mitochondria, you might be able to see some changes, and you could prove your point. Yeah.
Well, again, if you look at the other diseases, though, whether it's AMPI or even birdshot, when you look at the ellipsoid zone, that the fact that, and this is just two, I will tell you we see it in multifocal choroiditis, I think we see it in PIC, I think we see it in a bunch of other diseases where we will see ellipsoid zone reconstitution. Now, does it mean that it was always gone? What does it actually mean? I don't think we know necessarily. I mean, I will grant you that. I still don't necessarily understand how the ellipsoid zone band returns in syphilitic disease. But is it inflammatory disease that's invading, that's occurring? Is it the actual spirochete, which is Dan's favorite thing to think, that the spirochetes are out there? But I think it does tell you that there are probably features that allow us to predict, I think, which ones are going to recover and which ones won't.
Or is it just a loss of mitochondrial density? Because that's what's causing the EZ to form, right?
Yeah.
It's mitochondrial density. And if you lose that, you can potentially lose the EZ from that.
Yeah.
I think your spirochetes are in the choroid causing ischemia.
You think your spirochetes are in the choroid? But any other thoughts?
Vascular.
I was just thinking of some of the other conditions where I've seen recovery. We've seen it in autoimmune uveitis, where we actually treated with an anti-IL-6 agent and seen reconstitution of the ellipsoid zone. And there, with syphilis, you have a thickening of the outer nuclear layer. You've got the lumpy, bumpy appearance on the RPE, several things which could affect the optical effects of the ellipsoid zone. But in the autoimmune retinopathy, it's pretty much retina that's affected. You don't see those changes in the outer nuclear layer, yet we have seen reconstitution with therapy. So I think it is a real thing.
Yeah.
I mean, it's basically the photoreceptor. It's either the ellipsoid or it's the inner segment, outer segment, depending on who you talk to, because some people still feel it's inner segment, outer segment junction. But it's that portion of the photoreceptor. The nuclei may still be intact, so there's the capability of regeneration.
Yeah, excellent. Our last talk will be Dr. Chakravarti again, talking about the double layer sign or shallow irregular elevation. Is one more sensitive than the other as a prognostic marker?
So here are my disclosures. Now, it's a good idea to start with normal-looking outer retinal anatomy. The hyperreflective RP layer is normally closely opposed to Bruch's membrane. But in intermediate AMD eyes, those eyes that have soft drusen, irregular elevation of the RPE has been in the past shown to signify presence of new vessels on OCT angiography, but they don't leak. And when some of these eyes were examined when spectral domain OCT became available, researchers noticed that there was heterogeneous reflectivity between the highly reflective RP layer and Bruch's membrane. And Phil Rosenfeld did do quite a bit of work on this, and he showed that the double layer sign, it were co-localized to regions of non-exudative neovascularization and showed flow and on spectral domain OCT and on swept source OCT. Now, work from Robin Geimer's group suggested that certain characteristics of the shallow regular elevation more strongly associated with the presence of new vessels, and she termed these signs SIRE, and included the length of this elevated region being greater than 1,000 microns and the height to be less than 100 microns. But there are a number of unanswered questions. So in patients who have wet AMD in one eye, we all know that the fellow eye is at very high risk. Are there certain characteristics that increase the probability of progression to wet AMD in the second eye? So we asked the question, what is the predictability of the DLS versus the SIRE in these kind of high-risk second eyes? And is the rapidity of progression different if the DLS is absent, so there is no DLS, but just drusen? And is the rapidity of progression affected by other ocular and systemic risk factors? So we used the EDNA study, which was a diagnostic accuracy study. All patients were enrolled when wet AMD first appeared in the first eye. So not patients who had been sitting around with wet AMD in one eye for a long time. And because these patients were going to get anti-VEGF treatments to their first eye, the second eye came to the clinic with them. So we followed the second eye in some detail with various tests. And 145 of the 552 patients progressed to wet AMD in the study eye during time on study. And I'm going to tell you about this group. So the graders graded for the presence of the DLS, and they were previously trained on a data set provided by Nadia Waheed and Phil Rosenfeld, so that we had positive and negative cases in the subset. And then the volume scans of the EDNA set were examined for separation of the RP from Bruch's due to soft drusen. We called this irregular elevation of the RP, and if this was present, they were scrutinized for the features of the DLS, that's heterogeneous reflectivity, and then the most affected B scan with DLS was used to measure the length, the height, and also the number of B scans that were affected. And if this feature was only seen on one B scan, it was ignored. It had to be on at least two. Now, here are examples. These were all cases that were imaged in routine eye care, and you can see that these are foveal scans. Of course, the entire volume scans were examined. So there was no irregular elevation on the panel on the left. The one in the middle shows not just soft drusen, and then the one on the right shows features of DLS. Now, other features that were also graded were plenty of presence of soft drusen, subretinal drusenoid deposits, hypertransmission, and hyperreflective foci. If you look at the flow chart, you can see amongst the 540-odd patients who were originally enrolled, 459 fitted the criteria for inclusion in the study, and 268, roughly 60%, had irregular elevation of the RP that's plenty of soft drusen, and the DLS was present in 101 of these, and they split equally between DLS and SIRE 50-50. So there were some differences in the baseline characteristics by whether these patients exhibited the IE, DLS, and SIRE. Interestingly, female gender was associated with a higher frequency of these characteristics, but the other ocular features that were graded were evenly distributed. Now, Kaplan-Meier survival plots comparing time to development of exudation is shown here, and you can see that on the panels that panel on the left shows a strata where there's no, i.e. is the blue line. The second one shows where there's no, where there was DLS in the gold line, and the third panel shows the SIRE category. And as you can see here, whether you had irregular elevation of the RPE, the DLS or SIRE, there was an increased risk of progression to wet AMD. But when you look at the mutually exclusive categories, where you see by IE only, DLS only, or SIRE, you see the DLS and the SIRE completely overlap over each other. That is, the probability of progression to wet AMD was identical whether you bothered to measure these features or not. And the hazard ratios are shown here in the forest plot by the non-overlapping categories, and you see very clearly that the reference category was no irregular elevation, and then with drusen only but without any signs of DLS, there is an increased risk, and then with DLS and SIRE, the risk is increased, and smoking and family history also independently contributed to the increased risk. So here are my take-home messages. The predictive ability of the SIRE was no different to the DLS, and drusen without the features of DLS also increased the probability of progression to exudation, but the hazard was lower. Family history and history of smoking increased the risk of progression independently, but the effects were very small. And the DLS is a pragmatic biomarker. It's easily applied in the clinical setting and useful for counseling high-risk patients. So Phil and Nadia were very helpful, so want to acknowledge them. Here are our graders who did a lot of the work, and also to acknowledge the imaging technicians of the various health service facilities who contributed to the study. Thank you.
So how do you apply this clinically? So do you if you see this in a patient, do you follow them closer?
If you see heterogeneous hyperreflectivity, spectral domain OCT scans accompany the patients almost all the time, then you know that the risk of progression is faster. We did have some time to progression data as well, which we published in the ophthalmology retina paper, and it's obvious that many of these patients will progress within 2 years as opposed to 3 or 4 years' time, whereas if they have soft drusen only, the progression rate's slower. So you have a bit of leeway in counseling these patients. If they'll ask you, what's the risk to my fellow eye in the next 2 years or 3 years, gives them the opportunity to sort of know that their risk is lower if they have got no drusen at all. Some of these patients with wet AMD in one eye have hardly any drusen. That's something we learned, even though it was very typically wet AMD.
You maybe put these patients on home OCT and see if you can actually predict when they're going to.
That would be very interesting indeed, yes. And we look forward to Dan's work when in DRCR-NET, where they'll be looking at exactly these sort of patients. The one thing I would say is that when we compared our data to the PROCON study, their rate of conversion progression to wet AMD was very low. And I think that was because they enrolled a lot of patients who had been sitting around with wet AMD in one eye who were on low risk of progressing. So at first presentation is when you want to capture them, because we had around 9 to 10% conversion per year.
Usha, did you do any correlation with OCTA for the heterogeneous double layer size?
This study was started in 2015 and complete in 2018. So not all our sites had OCTA. So we have OCTA in around about 50 or 60 only eyes, and we haven't got around to really looking at it. I did do something after you spoke last time when you said that the OCTAs were poor quality we found that around 20% of the OCTAs that were collected were not of very particularly good quality, but we had 80% where they were certainly gradable.
Excellent. Thank you very much. Closes out our course. I think we've had some really great discussions. I'll actually give the audience an opportunity to ask any last questions. Panel, Dr. Martin always gets the last word. Anything you want to say?
No. Well.
Wow.
Well done.
Okay, wait, no. You said
No.
no. That's it. I'm kidding. What would you like to say, sir?
No.
I'd like to thank
I
our.
have one little question.
Yes.
Sorry, I hate to do
Yeah,
this.
no,
but
please.
I loved Glenn's talk about the IOI that you get with drugs. Now, I think it's great that if you have consensus in terms of reading center, but how do you apply it when the genie's out of the bottle, when it's in routine care? Can you provide sort of pragmatic guidance so that when these therapies come to the UK, we're always much slower to accept what goes on elsewhere, that we are in a position to give appropriate guidance to our clinical sites so that when they see these, what's the minimum that you would want to see to make the decision?
Well, I think the first thing is making sure that you can even see what you want to see. So to get a protocol where you can, to get people to do wide field imaging so you can see some of these things. And I think once people start, it's like the sun classification. People started using that for trials and in the clinic to, in fact, for billing purposes, to describe the patients. And I think once you start with a standardized system, people will look at it and start identifying the things they need to know. You know, what's a Kyrle's plaque? What's white? What's a focal area of whitening? What's sheathing? You know, people mostly know that, but I think once it's codified and people see it enough, they're going to start using it in the clinic.
Fantastic. Thank you again to our sponsors. Thank you to the panelists. They were fantastic. Have a round of applause for our fantastic panel. And thank you to the iVista team. This is your ability to get credit. If you do want to get credit, please just scan the QR code. I'll be around here if you have any other questions you want to chat with us. And thank you again. We'll see you. Have a great rest of your ASRS, everybody.